Dr. Subramaniam sir, shall we start? Subramaniam sir, it is 10 o'clock.
Right, sir. Sir, it is streaming on YouTube as well right now, sir.
Okay, right.
Can allow 1 or 2 minutes for participants to join, maybe 1 minute, maybe.
Subramaniam sir, are you there?
We already have about 55 participants, sir.
Yes, sir. Shall we start?
Yes, I think we can.
Okay. Good morning to all. Respected Dr. Subramaniam, Chairperson IP National Respiratory Chapter, Dr. B. A. Sharma, Chairperson elect, Dr. Manjunath, Finance Secretary, Dr. Sanjay Bafna, the National Convener for PFT module, my respected faculty, Dr. Parik, Dr. Pawan Kalyan, Dr. Sarika, my respected EB members, Dr. Modi, and all other members who have joined, and all my dear delegates. A warm welcome to you all on the occasion of launch of IP NRC Pulmonary Function Testing Module. As you all are aware that pulmonary function testing is an integral part of diagnostic algorithm of most of pediatric pulmonary problems. May it be demonstration of reversible airway obstruction in bronchial asthma by doing spirometry or PFT, trying to see for airway inflammation by Feno, trying to measure lung volumes or residual volume by plethysmography, or trying to see the diffusion of gases by DNCO in ILDs. PFT plays a very important role in pediatric pulmonology. In fact, the recent GINA guidelines have made it mandatory that if you want to label diagnosis of asthma, you must document reversible airway obstruction by spirometry. Without that, you cannot label it as asthma. So, keeping all the things in mind, IP NRC made this module to make the members aware of important aspects of pulmonary function testing. Although in this module, we will be concentrating only on spirometry, peak flow metry, Feno, but as and when demand arises and as and when things become more and more available, we will be discussing more about impulse oscillometry and DLCO and other things. But this module basically we will be stressing only on basics of how do you interpret and how do you learn spirometry, peak flow metry, and along with that, So we hope that whatever information which you're going to give it to today, it will be of immense use to you in your day-to-day practice. My sincere thanks to the team led by Dr. Bafna, who has done an excellent job in crafting the module, entire scientific content, entire workstation, and we hope that this will give you a very important insight. Thank you for Dr. Subramaniam to lead the team and giving all the necessary instructions and necessary know-how how to go ahead with this module. Thank you very much. So we have a short inaugural function. Following that, we'll have module run. I'll request our chairperson-elect, Dr. B. A. Sharma, to give his welcome message and blessings. Dr. Sharma.
Thank you, Dr. Awad. Respected Dr. Subramania, the President of IP Respiratory Chapter, Dr. Sanjeev Singh Rawat sir, Dr. Manjunath, Dr. Sanjay Bapna, Dr. Ankit Parekh, all EB members and OB members, and dear delegates. Today is a great day for IP respiratory chapter as we are witnessing the launch of another good module on pulmonary function test. The importance has already been emphasized by Dr. Rawat, how important the pulmonary function test for a common pediatrician in reaching or in monitoring the different chronic respiratory diseases. Our team of Dr. Sanjay Bapna, Dr. Ankit Parekh, Dr. Sarika, Dr. Pawan Kalyan has put immense efforts in making this module as perfect, as useful, as updated as possible. But friends, you will be the best judge. Their efforts have been given this module a very good shape, but I would request you to analyze it and give the positive feedback of your positive criticism, constructive ideas. So as Dr. Rawat has already said, that the module can further be upgraded as per the needs of the members. So friends, enjoy the module. And with this, I wish a great success to this module. Thank you so much. Jai Hind, Jai IP. Thank you.
Thank you, Sharma sir, for your kind words, and we look forward for your guidance and for your leadership to carry all our work of NRC forward in the next year. Thank you very much. I request our national convener of the module, Dr. Bapna, to give a short introduction what has gone behind this module and how this would be useful to all, and also welcome all the delegates. Dr. Bapna, please.
Thank you, Dr. Rawat. A very good morning to my dear colleagues from IIP NRC office bearers, my dear friends, faculty members, and good morning to all the delegates who have joined us on this Sunday morning. I think I must thank the IIP NRC team led by Dr. Subramanya, Dr. Rawat, Dr. Manjunath Jain Joshi, and of course the incoming president, Dr. B.S. Sharma, for providing immense support and inspiration to bring out this module. And of course, Dr. Ankit Parekh, Sarika, and Pawan has put in a lot of efforts, and there were a lot of meetings and interactions so that we bring this module as per the recent guidelines. And as you know, the guidelines about the interpretation have been updated as early as, as latest as 2019. Now, as Dr. Rawat has already said, in this era of evidence-based medicine, spirometry and documentation of other objective evidence of pulmonary dysfunction has become an essential part of not only pulmonology practice, but even in a pediatrician's office. I think this can be done. And I must congratulate for this bold step, because I think 10 years back, we used to have a debate whether spirometry should be done or, in the office practice. I would think that debate has been sealed with the guidelines now document and, emphasizing that spirometry is a part of diagnostic workup, and other tests, of course, should be done. And therefore, I think this is a very bold and timely step which IIP NRC has taken, and I must congratulate. This is a vibrant body. Every month, I think they're coming with a module, and a bold step in the sense because this is a skill-based module, and I feel that the initial idea was to create awareness and familiarize pediatricians with spirometry. But I would personally go one step further and say that so much efforts has gone, and I'm sure and very, very confident that at the end of this module, most of us would be confident and competent to perform spirometry in your office practice. And even few percentage of you take up this spirometry in your office practice, then I think that would be the success of this module. So we don't want you to just go with the knowledge of spirometry, but we want you to perform spirometry, because handful of pulmonologists in this country cannot take care of the asthma patients. And if all of you start doing spirometry in our practice, that's what I think the objective of this module is. And that would be the real success. And that would not only improve the asthma care in our country, but also would be very gratifying for all of you in your OPD practice. That would be real benefit and the objective of this module. And I think all my dear friends, Ankit and Pawan and Sarika, and of course, office bearers, Sanjeev, Manjunath, Subramanya, all of them, supported us very well. So wish all of you all the best and happy learning. And thank you so much, Dr. Rawat. Over to you.
Thank you, Dr. Bapna, for your words. And I think we again appreciate all the efforts you have taken to make this module and see the light of the day. And we thank you very much to be associated with this module for a long time and give all the updates and add more and more technical details so that people get updated. Thank you very much. Any activity of this nature is not possible because without technical know-how and technical support. We have got our finance secretary, Dr. Manjunath Sharma, who is a very techno-savvy member, and he helps us in all the technical progress which you see for IPNRC to bringing all these modules to you. I'll request Dr. Manjunath Sharma to give a welcome message, please.
I mean, I'm so privileged to be a part of the office bearers and part of IAPNRC. This has given immense learning opportunities just not for me, but for everyone like me in the field of respirology. I mean, it's the effort which has gone to make this module is immense. So everybody who's attending this module should learn it and try and emphasize and practice in their day-to-day practice. That is when the purpose of this module will be served. With this, I thank you once again, Dr. Rawat sir and Dr. Subramanya and Dr. B.S. Sharma. And thank you, Dr. Sanjay Bafna, for heading the entire team of the PFT module. Thank you very much, sir. Dr. Rawat sir, please.
Thank you, Dr. Manjunath, for being a technical pillar for IPNRC, and thank you for all the support which you have given it to us. Thank you very much. All these things, activities which you are witnessing in IPNRC, it is because of the vision of our chairperson, Dr. Subramaniam, who has a very clear vision regarding how things are going to go ahead, and we hope that he continues to lead us and he continues to guide us in future activities of IPNRC also. Thank you very much. I'll request Dr. Subramaniam to give welcome message and also inaugurate the module.
I am audible, Rawat
Yes.
sir?
Yes, sir.
Okay. Respected Dr. Sanjeev Singh Rawat, the man of mission IAPNRC, and our wealthy treasurer who started with a single digit in respiratory chapter, few lakhs. It has now become 500 crore plus respiratory chapter. It is something that no other country, no other chapter has seen that phenomenal financial growth that we could witness in the past. And for the communications part of it, we have already crossed 2000. We are going to break all Virat Kohli, Tendulkar records if possible. By the time we finish in December with high note. This is just possible because of efforts of people like Dr. Sharma, Dr. Rawat, Dr. Manjunath, and the team. I would say, I don't want to take the names, the entire team of charged pulmonologists and the committed pediatricians, plus the magnanimous participants. I don't think without participants, anything that we do is going to be successful. Chris Gale, sixer in a West Indies pitch won't mean anything, but in an IPL in front of 50,000 crowd, it means a lot. I think you understand the point. So it is the same sixer, it may be the same subject, but without audience, it won't mean anything. We have a record number of registrations crossing 750 to 800 for this workshop. I don't think it is, we have seen any of our modules running anytime with less number of people. Now already we are reaching close to 200 participants joining live, and many would just join in a matter of another 5-10 minutes. And we also see that there are no dropouts from the sessions. The number in the beginning and number in the end would remain same or even higher, never less. So that also speak, even till the vote of thanks, people won't log out of our chapter activities. And this is how we have patronized the chapter. And I would wish that on this platform, I would request Manjunath to share the membership link in the chat box. And those of you who are not members, you can just do online. It's just a click and 2.5 Gandhi notes for you. Nothing more than that, you know. So therefore, we wanted to reach 10,000 by December. We have to cross another 8,000. That's a huge target that we have kept for ourselves and hope that we are going to achieve. There are no part of the respiratory tract that are left without a module. This is tsunami of modules that you have seen in past 3 or 4 years from the respiratory chapter, starting from basic pulmonology topics to advanced pulmonology topics. I don't think you have anything left. And therefore, my dear friends, I would say, please join us in our family. Who knows, one of you may be conveners of tomorrow's module. Just 4 years back, Manjunath was just traveling with me as simple as a delegate, next as a faculty. Now you see him as treasurer. And I don't think it is not impossible. Now coming back to the module, thanks to the team led by Dr. Bafna, whom I would say future secretary of respiratory chapter in the coming days and then president. I wish him all the best for the commitment, and also he's a teacher of pulmonology fellows in Pune. So we are proud of you and your scientific commitment to the chapter in all these years. Dr. Pawan Kalyan, who is a young fatty pulmonologist, very contented man, fulfilled man, and he is fulfilled with science. The young and energetic Sarika, who is a find from 4 or 5 years back, and she is now also both in the west and east, and she is very good, very fantastic academician. And Dr. Ankit, who know he is in the best part of the country from Delhi, and he is the most committed for the chapter even before me could come into the chapter. So we have galaxy of the faculties who have put in their day and night, burn midnight oil and put their sweat in. Dr. Shishir Modak, Dr. Modi have joined from the EB. So welcome to you as well. And many members in absentia who are watching us. I don't think any other president had this privilege of inaugurating so many modules in lifetime. So I would pray Lord Ganesha to take the chapter forward, and with his blessings, we are all human beings, So therefore, he should bless us, and it's the God who inspires us to inaugurate. So I request Almighty to enable us to inaugurate this pulmonary function test module. Only one line from me: this should not be sensitizing webinar or series of lectures, as Dr. Bafna rightly told. This should result in you interpreting pulmonary function test. Any science or anything, any task would look very big. Moment you start doing, it becomes easy. When ventilators came, we thought, how can we ventilate? It's so difficult. Who will remember all that? When you start doing it, it becomes easy. ABGs, you remember, even if you are taught 10 times also, unless you see an ABG and interpret, it's difficult. So my dear friends, I've given you a couple of analogies. We have very easily understandable functions in other parts. They are all biochemical tests. We have got renal function test. We have got liver function test, very easily understandable by values. But it is so difficult. You can't have cerebral function test and pulmonary function test, and you can have cardiac function test. I'm just giving you how to test the function. I think the days have come when you want to know the vitality of performance of a respiratory system, and that is measured by our breathing mechanics, basically by measurement of volumes and pressures, and that is measured by our favorite spirometry, so on and so forth. But it is not enough. We may need more parameters. So therefore, you will have two categories of pulmonary function tests. Very simple bedside tests, which were popular, like blowing a candle and blowing a machine, so on and so forth. People in the past used to just objectively measure something. It went on to something advanced, which we have got what is called as basic pulmonary function tests. We can do couple of them at home and couple of them in your clinics. And we can have advanced pulmonary function tests, which means a lot for the researchers, as well as in future, it can be on the bedside of a clinician. I think I have given you the glimpse of spectrum of pulmonary function tests that are available, but mind you, do not get bogged off with too much of glossaries with Bafna, Ankit, Sarika, and Pavan are going to use. Don't worry about FE, F50. If you don't understand, chill. Don't worry. It's not a rocket science. Moment you get in, you feel that is pretty simple. All that I wanted to tell you is please read the words very slowly and carefully, because every word is self-explanatory. It is spirometry. So it is spiral, you get the volumes. Previously, we used to have the volumes. It is peak expiratory flow rate. So if you start spelling them slowly and relax, you will understand everything. If you say PFR, 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 then after the session is over, what is this PFR? So that happens. So relax, make it simple and learn, and we will simplify it, and do not shy away from interactions. I have taken a couple of more minutes. Please note down the things, be active in the chapter, post any PFT in your clinic which you have not understood. One of us will analyze it for you. This is called as extended post session continued education with the chapter is ready to give. Please interact. Don't worry. I get at least 5 to 6 cases every day on WhatsApp. That is very nice of you people to get continued learning. Even many, I will give the numbers of many resource persons. You can keep interacting and keep learning. And that's how we remain active, alive, and resourceful. Thank you very much for giving me this opportunity. Please don't shy off. Don't log off. Continue and make use of this opportunity to learn. And thank you very much. And all of you, and wish you happy learning. And may I declare this module inaugurated. And there could be another 5, 6 which you are going to inaugurate by December. And thank you very much.
Thank you, sir, for your kind words, for your guidance, for your leadership. And we hope that whatever work we have done in this IPNRC for past 2 years, it will help the members immensely, and they'll help in their practice, their education, and their way how do they treat the patient. Thank you very much. And now we straight away go to the module. I wish to congratulate all of you because we have got 800 plus registration, and definitely all of you are going to learn spirometry in a very simple way in which you can use it right from today itself. Whatever questions you have, you can post in the Q&A box or chat box, and we'll try to answer all of them. So now it is over to Dr. Bapna, who will be the master of ceremonies, and he would conduct the module. Now, Dr. Bapna, please.
Thank you, Dr. Rawat. So with this brief introduction, I think we will straight away go to the beginning of the module. Let me share this screen.
It is visible, sir.
Yeah, but so good morning and welcome back to all the delegates for this module on IPNRC pulmonary function testing module. As has been discussed, pulmonary function test encompasses lot of tests, and we are going to discuss few of them. These are the contributors of the module, 4 of us. This is today's agenda. I will be giving you a brief introduction of various pulmonary function tests which are available. Then we will have a talk on basics of spirometry, followed by how to do a spirometry procedure. I will be talking on spirometry interpretation. Then we will have a break, and whatever we have learned will be applied in the real life cases. Dr. Pavan will be discussing that. Then we have brief sessions on peak flowmetry and Feno, which are also simple basic tests can be performed in office practice. So as all the speakers have said, documentation of pulmonary function abnormality has become an essential part of diagnosis of asthma and other chronic pulmonology diseases. And I would be giving you a broad overview of various tests which are available, and depending on the type of patient, the selection of the test would depend. Now, it's an important test which is underutilized for various reasons, particularly in pediatric population. All of us are aware of one pulmonary function test, that is peak flow, which we do in office practice, and spirometry, which is has become in vogue now for asthma. But there are many other tests which are available, like plethysmography, DLCO, etc. And this must be done in select patients. So what are the parameters which are measured? As basically our idea is to measure what are the lung volume and flow, but at the same time we want to know about the lung mechanics. Therefore, we also measure resistance, capacities, capacitance, compliance, etc., depending on the type of the test. As we said, they are underutilized, particularly in pediatrics, and the reasons being, the first thing is most of these tests would need cooperation, and therefore feasibility is an issue. Some of these tests are not available, like DLCO and body box may not be available. You need a technician to actually perform this test, and somebody who can interpret it well. And of course, sometimes the reference data for this this test may not be available. So these are the reasons. But with the more and more people getting interested in the test and more data coming up, now pulmonary function test is becoming more and more popular, and we have centers where most of these tests have been done. So when we should refer the patient for PFT and why we should be doing PFT? First and foremost, utility of pulmonary function test is, of course, it helps in diagnosing a pulmonary respiratory disease. So broadly, you can try to categorize the respiratory disease depending on the test. And once we have diagnosed or make a broad diagnosis of respiratory disease based on, of course, a clinical information and the pulmonary function test, the next step is what is the degree or severity of impairment. And many tests would tell you that, like FEV1 will be an important parameter to tell us what is the severity of asthma in that patient. After that, of course, we start the therapy for that patient, and how is the therapy impacting the disease. So it is also an important follow-up tool. You have started ICS in an asthma patient, you want to know what has happened to the FEV1. Of course, you would be monitoring the clinical symptoms too, but it is very important to monitor the pulmonary function. So it's an important monitoring tool. As we said, impact of therapy as well as disease may progress. So what has happened over a period of time to the disease, whether the FEV1 is progressively declining in spite of the treatment, what has happened to the TLC in a restrictive lung disease. So this all can be monitored by doing a pulmonary function test in general. And of course, it would also obviously tell us about the prognosis in that patient. Many times pulmonary function test needs to be done in preoperative care of the patient, and this is again something which I would like to emphasize. Any patient like a scoliosis patient going for surgery, pulmonary function test spirometry is must, because you want to know what is his lung volume before scoliosis, what is his FEV1 before he undergoes the repair, and so that it is very important intraoperatively for the anesthetist to take the due precautions, and also post-operatively to follow what is the improvement which has occurred. A child who is nowadays bone marrow transplant is very common. every patient who undergoes bone marrow transplant should have a preoperative lung function test, because transplant itself can result in a chronic lung disease like bronchiolitis obliterans, and therefore you want to know what was the baseline status of this patient. Unfortunately, this is the area, again, it is not addressed, and many times patient would come to you with some problem and you don't know what was the actual status before the procedure. So there are various other areas where you need to, like chemotherapy patients would have some chemotherapeutic agents which would lead to lung fibrosis. So you need to have the lung function test performed before you start chemotherapy in select patients, not all patients, but in select patients where you are going to use such respiratory toxic chemotherapeutic agents. And of course, PFT is an important research tool because we want to know the trends, we want to know the FEV1 or other parameters in different population. We want to know the impact of, say, tobacco smoke on the pulmonary function. We want to know the impact of pollutants on pulmonary function. So a lot of research can be done with the use of pulmonary function test. So these are the various indications of performing a PFT. So how does it really help in diagnosis? Because that is the area where we actually are interested, or the pediatricians are interested. So we can categorize the pulmonary respiratory disorder as an obstructive disorder, a restrictive disorder, or a mixed disorder based on the results of your pulmonary function test. And of course, diffusion defect may be an isolated or a part of this disorder. So this can be done if we do the pulmonary function test. And once we have categorized the disease, it becomes very easy for us to further go down and narrow down our differential. So it's an important part of diagnostic algorithm. So what questions are we trying to answer when we do a lung function test? First question, we want to know, are my airways patent? So here we are talking on obstructive airway disease. I want to know what is the total lung capacity. Here I'm talking of volumes. It's basically a restrictive lung disease which I'm trying to address. And is my diffusion apparatus working well? That means everything is normal, the lung airways are normal, the lung capacity is okay, but whether the gas exchange is working well, that's what we are trying to answer. So these are the three important categories of diseases which basically we are trying to diagnose. Now, obstructive diseases, the common, so these are the diseases and the type of test which you are going to perform and the parameters which we are going to test. For example, asthma, obstructive disease like asthma and COPD, the test which you would like to do is spirometry or IOS in a younger child. And what we are going to measure is flow and volume in spirometry or resistance in IOS. In a restrictive disease like interstitial lung disease, a neuromuscular disorder, or a chest deformity like scoliosis, you are interested in measuring the lung volume. And the test which you would select is body box or a gas dilution technique, which will give you an idea about various lung volumes. Whereas if you are, there are certain tests which will tell you about the gas exchange. Of course, ABG is a bedside test which also talks about the gas, tells you about grossly about the gas exchange. But if you really want to know at a micro level what is happening to the diffusion, the test which you would perform is DLCO, diffusion capacity of the lung, and it measures the diffusion capacity, and the applicability is in interstitial lung disease or a pulmonary vascular disorder where the diffusion is also affected. So these are the tests which are commonly done: spirometry for obstructive disease, body plethysmography for a restrictive disease, DLCO again for a diffusion abnormality, which can be a part of a restrictive disease. But there are other more advanced tests which are also available in some centers. For example, you have a neuromuscular disorder and you want to know the weakness, respiratory muscle strength. There is a test which is available which is known as inspiratory and expiratory pressure, which is measured by a simple instrument, but it needs some expertise. And what we measure is global strength of respiratory muscle. This is helpful in patients for example, of DMD over a period of time to follow these patients. And we are trying to measure volumes and we are trying to measure the flows, but we also want to know the degree of inflammation. And nowadays we have Feno as a test or a measurement of eosinophilic inflammation, which is again a simple test which can be done at bedside. And Dr. Ankit would be taking us through about Feno. You can do a functional assessment of the patient. The patient has a chronic pulmonology problem. Actually, you have seen the volumes and flows, but what is actually happening to the patient in his day-to-day life? How is it affecting his function? So various exercise testing tests are available where you measure the endurance of the patient, and the indication would be any chronic lung disease. A word about infant and preschool PFTs. Now, we all know that we can perform many tests in 6 to 12 years old children. Spirometry is very easy to perform in 5 to 6 years, and many other tests like DLCO can be done after 10 years. But infant and preschool PFT is really a challenging field. Availability of these other tests are limited, and there is a limited reference data about preschool children or infants. But all the while, these tests are performed in specialized centers, particularly in some of the international centers. And I'm sure in due course of time, we would also be acquiring those instruments and equipments. So in preschool children, IOS or FOT can be performed, which I think many centers, including our center at Pune, is doing. We can do an interrupt technique to do a measure resistance. And of course, FRC can be done by gas dilution in specialized centers. Infant PFT is, really very specialized centers are performing this, and many of the research laboratories are doing this. We can do infant plethysmography with a special equipment. You can do FRC by gas dilution. FOT can be performed in infants after sedation. So this is just to sensitize you that yes, lung function test also be performed in infants and preschool children. So thank you very much. This was an overview of various tests which are available. Of course, as we discussed, we are going to discuss mainly spirometry. That is the purpose of this module. And we will also discuss in brief about peak flowmetry and Feno. With this, I invite Dr. Ankit Parekh for his first talk on basics of spirometry. I request all the delegates to please put in your questions in the chat box so that we can answer at the end of the talk. Over to you, Dr. Ankit.
Sanjay, we can take two questions because a couple of questions we can take after every talk, and then
Yes.
also we can
Definitely.
There are two questions. One
Yes.
question is that what is the advantage of DLCO or ABG?
Shall I stop sharing my screen?
Yes, please. One
Yes.
one question is what is the advantage of the DLCO over ABG?
Okay, so ABG is a very gross test which is basically telling you about the oxygenation, about the CO2. So it will tell you about the also tell you about the diffusion grossly. It will not tell you what is the problem. Means even if you have an obstructive disease, whether you have a restrictive disease, whether you have a diffusion problem, your ABG will be abnormal. So it is not telling you where the problem lies. So it will tell you that there is a problem and you need to identify. So you may be hypoxemia from top to bottom. You may have a problem in the environment, in the airways, in the parenchyma, or at the diffusion level. Whereas when you do a DLCO, you actually are measuring the diffusion capacity of the lung. So when your DLCO is abnormal, you have actually know what is the site of abnormality. That means your airways are functioning, your airways may be functioning well, your DLCO will be normal. If your lung parenchyma is grossly abnormal, then your DLCO may be normal. But if there is an interstitial lung disease, your DLCO will go down. And if you suppose have a restrictive lung disease and it is because of neuromuscular problem or a skeletal problem, then your DLCO still will be normal. So in a restrictive lung disease, you can help, the DLCO will help you to actually localize the problem. It is in the interstitium. So I hope it is clear that the ABG will grossly tell you the problem, but DLCO will localize the problem to the diffusion apparatus, which is your interstitium or alveolo-capillary membrane. So it's a membrane abnormality. That's how DLCO will help. It's a more sophisticated test to help to rule out other diseases. And second place where your DLCO will be abnormal is a pulmonary vascular disease. So everything is normal, but the patient has hypoxemia, and you do a DLCO which is low, which tells you that there is a problem in the pulmonary vasculature.
Okay, then one question was that what is the advantage of 20 number count over test for respiratory muscle weakness?
Yes, I think it's again, as we said, this is a single breath count test which we do for many patients or any chronic pulmonary or acute pulmonary patients. It's a very gross test to tell you what is the, it actually does not give you an idea where the problem lies. It may tell you that, yes, the child is breathless or tachypneic or has a respiratory distress. Whether he is hypoventilating, whether he has hypoxemia, it will not tell you. Exercise testing is a specific test which will tell you more about the degree of impairment. So it's a gross screening test, I would say, in a bedside.
Okay, so I'll request all the delegate to keep posting their questions. We are having an open house at the end of the lecture where we will take all the questions. We will take one or two questions at the end of each talk, but all questions we are going to take in the open house session. So I'll request Ankit sir to start this session.
So a very good morning to everyone, and in the next 20-25 minutes we'll talk about the basics of spirometry in children. So we'll talk about some physiology. We'll talk about when spirometry is indicated, when you should actually avoid doing a spirometry, and then we'll talk about what you get in a spirometry. So what are the volumes and capacities and loops and parameters that you would get when you look at the report. So basically, what is a spirometry? So it is basically a physiological test that measures how an individual would inhale or exhale the volume of air as a function of time, right? And it is definitely the gold standard for diagnosis of obstructive airway diseases. And as already talked about, that for restrictive lung diseases, you can perform a spirometry, but the gold standard remains as the lung volumes. And for interstitial lung disease, you need a diffusion capacity. But for obstructive airway diseases, it is the gold standard. It is an objective tool, right? And it gives you values, it gives you numbers, and it is dependent on the patient and the effort of the patient, right? So that is something which everyone needs to know. So it is not like a blood test. It's not like a CBC test when you just put in blood and you get an answer. The patient has to actually perform, and that is something which is sometimes a problem. But you have to know that there are lots of variables which are there behind a lung function test, which are not there with many other tests. So the question is, why is it relevant to a pediatrician? Why do we need to talk about a lung function test? And why do I need to know about it? Well, most patients with asthma or chronic cough present to a pediatrician, right? And most would be managed by a pediatrician. And in these situations, doing a lung function, especially a spirometry, would help in better diagnosis and management of these children. So there's absolutely no doubt about it. Sorry. So there is absolutely no doubt about the fact that for management of these children, we actually need to do a lung function test, right? And effective management of patients who who are on regular therapy. So if you're running an asthma clinic, depending on the number of patients you are dealing with, it's extremely important because it leads to a better management, and you will understand this as we go across the module, and it improves the patient satisfaction, right? So you will be having a lot of patients with asthma where one, your clinical diagnosis is asthma, and you will find that a lot of patients and parents will not be very happy with that diagnosis and would be roaming around. And documenting a lung function gives a proper diagnosis and emphasizes the need for preventive therapy. And it helps during follow-up as well, because it shows the patient objective numbers where they can see that their child is improving without doubt. So the indications for doing a spirometry is basically for diagnosis. So we are trying to diagnose a child with chronic cough or a child who presents to you with cough and episodes of wheezing. So you are thinking that this child might be asthma. And obviously, they can be differential diagnosis, which we'll talk about. Then it helps you in monitoring as well. So you've put the child on inhaler therapy, and then you want to see this child in clinical follow-up. And when you repeat a lung function, you realize what's happening. And there's a lot of data which tells us that if you do it clinically versus if you do it clinically with a lung function, then there would be a lot of patients who seem to be well clinically, but they have an obstruction going on in the lung function, right? So that is the reason why it is very important to do a lung function and follow up as well. And as Dr. Bafna already said, that lung functions would be a part of a lot of preoperative assessment, lot of other disorders like patients going for bone marrow transplant or chemotherapy, where you want to see the lung function prior to starting therapy and see what's going on later. And obviously, it remains a research tool as well. So the basic indications would be classified as obstructive lung diseases and restrictive lung diseases. So in obstructive lung diseases, the most common diagnosis which most people would be seeing would be asthmas. And as we said, it helps in diagnosis. It helps in assessment of severity and control, right? So it gives you an objective evidence. What is the FEV1 which is going on? What happens with treatment? And they are actually well controlled or not. Then obstructive lung diseases could be in the form of bronchiectasis, which might be a non-cystic fibrosis bronchiectasis or a cystic fibrosis bronchiectasis. Then you can have rare disorders like bronchiolitis obliterans and primary ciliary dyskinesia, which obviously requires a lung function for monitoring and follow-up. Now, in restrictive lung diseases, children with neuromuscular disorders do require to be followed up clinically and require an annual lung function or sometimes even every 6 months to understand what's going on. And the most important prototype of this is Gaucher's. But you have other spinomuscular atrophies and other disorders as well. Then children with scoliosis, which may or may not be associated with neuromuscular disorders, and patients with interstitial lung diseases, right? So these are the indications of doing a spirometry. And in many patients with interstitial lung diseases, your spirometry may not be diagnostic. It does not tell you whether it is an interstitial lung disease or it is something else. It does tell you whether it is a restriction or not. And it helps you immensely in follow-up, looking at treatment. So you treat a child with supposedly a pulmonary hemocitosis or a non-specific interstitial pneumonitis. And when you follow up this child with your treatment, you realize how the child is doing. It helps you in titrating your treatment. It helps you in deciding what needs to be done next. Now, what are the contraindications when you should actually not do a spirometry? Well, there are no real big contraindication. This is just to complete a list. Well, any child who is obviously sick, you cannot do a lung function. That is the most important thing which everyone realizes, right? So a child who has a respiratory tract infection, obviously, a child who has hemoptysis, who is bleeding, you don't try and do a lung function because it can induce a bleed. A recent brain surgery, eye surgery, cerebral aneurysm, a recent MI or stroke, uncontrolled hypertension, non-compensated heart failure, and any child who has a pneumothorax, recent thoracic or abdominal surgery. So the basic thing is any child or adult who's too unwell, the clinical sickness is more important to deal with than doing a lung function at that particular time. It does not, help or answer the particular question. There are some relative contraindication where you can think about doing a lung function, and at least it helps you in interpretation that you had that factor along with, and you're trying to look at lung function in that respect. So smoking is one, consumption of tea, coffee, or caffeinated drinks, a heavy meal, heavy exercise 1 hour prior, taking bronchodilator. So I think this is the most important thing which we should be careful about, that when actually a child has taken a bronchodilator. So a child gets nebulized 2 hours before, and then you repeat a lung function and you realize the lung function is normal. So that is something which is important. Be careful about on what drugs they are. So if they're already taking a LABA, then your lung functions can be normal. But sometimes you want to do a lung function on the inhaler which they are taking, because you are not interested in the diagnosis. The diagnosis is already made. Now what you are looking at is the degree of control. So in these situations, you're trying to do a lung function on therapy, on inhaled corticosteroids with the LABA which they are already taking. So you're not going to stop that for assessment of control. But if you're trying to do that for diagnosis, then yes, it has to be stopped around 24 hours before. A lot of patients now, we use tiotropium. You have to stop it around 2 days, expiratory around 12 days, short-acting beta agonist around 6 hours. So at least when you're interpreting, you need to know what's going on in this child. So the interpretation of lung function has to be in this context. Right, now let's understand the basic physiology of the lung function. And we used to read this when even in the first of our medical education. Right, so as we all understand that this line, this wavy line is actually the tidal volume, and we all breathe on this tidal volume usually. Right, so this is the TV which we talk about, and the child would inspire from here and can go up to this level, right? And this level is what is the inspiratory capacity of this child. So it is a combination of the tidal volume and the inspiratory reserve volume, which forms the inspiratory capacity. Now, it is important to understand that if you're trying to do a spirometry, unless until the child achieves the inspiratory capacity, your expiration will be suboptimal. So when you're trying to coach a person for doing a spirometry, breathing in up to the total lung capacity or complete inspiratory capacity is extremely important. So that's the first step to understand spirometry, right? So if I have not taken a deep breath or enough deep breath, then the volume of air which is going to come out in expiration is obviously going to be less. And what you're going to get is a pseudo-restrictive curve, right? So deep inspiration to a lung capacity is important. And then this phase is followed by a forceful expiration, right? So the child expires from the top here, goes on, reaches to the expiratory reserve volume, goes on. So you blow out fast, but you continue to blow out till you reach the residual volume here. Fine. And at this point of time, no more air can be blown out by the child, and whatever air remains is the reserve volume, right? And the amount of air which can be blown from this point to this point actually forms the vital capacity. And when you're doing a spirometry, it is actually you're forcing the vital capacity. You're doing it intentionally. You are blowing out. And that is the reason why it is called as an FVC, or a forced vital capacity. Right. So the procedure, just to summarize again, is full inspiration to total lung capacity, a forceful and hard and fast expiration, and continues to a residual volume, right? So that's the whole maneuver about. Now, what you get here, sorry about this. What you get in the display, right? So you have done a maneuver, and obviously we're going to talk about it again and again. So what you get in the display is two graphs. So it gives you a flow volume loop and a volume time curve, right? And please understand that the values carry no meaning if the test has not been done properly, right? So unless until you learn to look at the graphs, the values of FEV1 and FVC mean nothing, right? So the learning to appreciate the graph of the spirometry is extremely important, right? And then you get measures. So you get two volumes and two flows, and you can have more things as well, but these are the most important. So you have an FVC, or the forced vital capacity, and you have an FEV1, which is the volume of air which is expired in the first second, and we'll talk about in the next few slides. And then you have flows, the most important being the PEFR, or the peak expiratory flow rate, and then you have FEF, which is the approximation of the flows between 25% to 75% values, which we'll talk about in the next few slides. And it is considered to be a marker of small airway disease. Now, what you don't measure is the residual volume, the FRC, and the total lung capacity. That you can get if you're trying to do a lung volume assessment, and that is required in some patients with interstitial lung diseases. But for most patients who present you with chronic cough, asthmas, and follow-up of interstitial lung diseases, doing a spirometry is something which does the job. Right. So let's talk about these spirometry volumes. So you have two terminologies here. You have FVC, which is your forced vital capacity, and then you have FEV1, which is the forced expiratory volume in the first second. Right. So it simply means that the graph which I have shown you, the child tries to blow out. The total volume of air that can be exhaled forcefully from the top, that is your total lung capacity, tells you about the FVC. Now, usually when someone is performing the spirometry, all of this air can come out usually in around 6 seconds in more than 10 years of age and adults. In children who are less than 6 years of age, all of this air can actually come out in 3 seconds. And then even if the maneuver is continued, no more air can come out. Now, if the child does not blow properly and stops in between, then your FVCs are low, and they're erroneously low. And that is the most important error in spirometry which you get. Now, FEV1 is the volume of air out of the FVC which can be blown out in the first second. And usually what we see is that around 80% of the air or the volume can be blown out in the first second itself. And whatever is left, gets out of the lungs in the next 2, 3, 4 seconds. So this FEV1 is something which is extremely important. And the ratios of the FEV1 to FVC actually helped us to characterize lung diseases in many ways. In healthy individual, as I said, around 80%. Now what we use is the Z scores and not just the percentages, because the percentages can be erroneous and may not be equal for all ages. But as a general rule, people would take it as around 80%, although it can be variable. Now, in most healthy individual, as I said, the volume of air or the FEV1 can be expired in around in a second is approximately 80% of the total volume. But in patients who have obstructive lung diseases, when their airways are tight, because of inflammation or remodeling and so on, depending on the type of the disease, the amount of air which comes out in the first second would be low. Okay, so this is what happens in a normal person. So in a normal person, as you can see, this is the FVC, this is the FVC, and this is the time axis. And what you see is that this is the portion of FeV1, right? So in 1 second, most of the volume is actually blown out, and which is usually 80%. And from this 1 second to in the next few seconds, which might be 2, 3, 4 seconds, all the air which can be blown out, right? And whatever is left is the residual volume. So this is what happens. And as you can see that the graph has plateaued here, right? So after 2 or 3 seconds, no more air is being blown out. And the graph actually plateaus. And this is the graph which you get as the volume time curve in a spirometry. Now, in children who have obstructive airway diseases, which is the commonest and our interest for today, which is asthma, then in obstructive diseases, as you can see, the resistance would increase, and the air which has to come out from the airways becomes slow, right? And hence, the child might be able to, push out the total amount of air which he has to. But the time duration is significantly increased, and hence the FEV1s are disproportionately reduced in comparison to the FVCs. So if you compare this graph with the previous graph, what you can see that in 1 second, the child actually can bring out only this amount of air. So it might be 80% in the previous case, and it might be lower significantly in this. And as you can see in this graph, this graph hasn't plateaued till around 5 or 6 seconds, right? So the child can still bring out all the air. So the forced vital capacity would still remain the normal. But the amount of air which comes out in the first second is significantly lower. And hence the FEV1s get disproportionately low. In some situations, what even we find is that the FVCs also get low because of the severe obstruction. And at that point of time, children with asthma can have an added restrictive component as well. It becomes a mixed dysfunction sort of a thing. But in most patients with asthma, it is a disproportionate reduction in FEV1 compared to the FVCs. Okay, now what you get is this graph, and which is the FV loop. And remember that in this, there is no time axis, right? So this is a plot of flow with volume, right? So you have the flow here on this axis, and you have a volume on this axis, right? So there is no time. You have a volume with time curve, which I had shown you, and I'll show you again. But this is a classical FV loop, and this gives you immense amount of information. And without examining an FV loop, spirometry is impossible. Now, the part which is below the line is the inspiration, and part which is above the line is actually the expiration. A lot of people get confused and believe that this is the inspiratory part and this is the expiratory part. That's wrong. The whole of the loop above the line is actually the expiration, and the loop below is inspiration as marked. So this is inspiration and this is expiration. Right. Now, you have volume here and you have flows here. And we just talked about it. Right. And the child actually starts to blow at this point of time. So the child takes in a deep breath, right? The child has volume of air inside the lungs, and the child has taken a breath up to the total lung capacity. So this is the point of total lung capacity, right? And the child starts to blow out from this point, and the flow would increase. So as the child blows fast and hard, the flow would increase and would reach to the PEF. So the peak expiratory flow rate is the maximum flow which a child can achieve. Now, after this PEF has been achieved, obviously the flow is going to decrease in all healthy individuals, and then the flow reduces and turns out to zero when no more air can come out. And this is the point which we called as the residual volume, right? And this whole is the forced vital capacity of this child, or the FVC. This is the total lung capacity. Now you have two more points which are marked here, and which are called as the MMEF, or the maximal mid expiratory flow, 25 to 75%. So what is done is that on the descending part of the loop, from the 25th percent to the 75%, we take the average of the flow, and that is what is known as the maximal mid expiratory flow rate. And it is thought that the MMEF helps to understand about small airway disease. Now, this is the second graph which you get, and which is the volume with time graph. So there is no flow here. So you have expired volume here, and you have time here. And as you can see that this is the point where the FEV1 would be reached in healthy individuals. It might be in disease individual that the volume would be significantly low. Now, the most important utility of the volume time graph is that it tells you about for how many seconds actually the child has expired. And I told you initially that the most important problem in children with spirometries is that they would actually stop blowing, right? So they would start blowing and they would stop blowing at around 1 second or 2 seconds, right? And in these situations, the FVCs are markedly reduced, right? But that is actually an error. And so that is what is known as a pseudo restriction, right? And if you don't know for how much time they've expired, right, your interpretation of that curve would be suboptimal. So you need to look at the volume time graph and see for how much time actually they have expired, and hence it allows you to evaluate the completeness of test. So in a lot of children, what we realize is that you have to interpret the graph, but if you know what has happened, then the interpretation can be done in that context, right? So that is the reason why this graph is extremely important. So this is the point where FEV1 is reached. Then you have the FVC, which is reached at this second. As you can see, the graph has plateaued somewhere around 4 seconds, which means no more air can come out, and you need to stop the test at this point of time. And as you can see, the FEV1 to FVC ratios are approximately 80%. Okay. Now, then we come to the flow measurements, right? So we have talked about volumes till now. So the peak expiratory flow, it is the maximal expiratory flow which can be achieved after a forced expiratory maneuver, and it is obviously represented in liters per second. It occurs early in the FVC maneuver. So the peak of the graph actually is the PEF. It is dependent on the effort of this child. So if the child doesn't take a good effort, the PEF can be erroneously low. It basically reflects the larger airways. And the problem is that it can be normal even when the patient has a marked small airway obstruction. And that is a principal reason why the PEF actually has gone into a bit of disrepute. So this is the area when the PEF appears, and as you would understand that the child just needs to blow out and doesn't need to continue doing the maneuver as you would do in the FVC or the spirometry maneuver. So this is the PEF. Then the FEFs, or the maximal mid expiratory flow rates, as they are also called, it is a sensitive indicator of small airway disease. It appears as a concavity on the flow volume loop. And it can be abnormal even when the PEFR and the FEV1s are normal, right? It is expressed as liters per second. The problem what most people would face is that it has a very wide range of normalcy. So the sensitivity might be high, but it is not specific. That is a very important reason that most people don't rely on the FEF value, which might be 25% or 75% of the average. So that's a big problem in especially with the pediatric population. So this is how people would do it. This is the FEF max, which is the PF, and then you have FEF 25, 50, and 75. And you can take the average of these, which is the FEF 25 to 75. But these values are sometimes non-specific. That is the most important problem. Right. So this is the way it is marked on the graph and it is calculated by the software. What we all need to know also is that you have quality control criteria called as the QC criteria for preschool and school children, and these should be met, right? Unless until they are met, your values don't carry a meaning. So it talks about back extrapolated volume of less than 5% of the forced vital capacity or 100 ml, whichever is greater. So it basically indicates the start of the test, right? It also talks about the end of the test criteria. And usually it is taken around 6 seconds for more than 6 years and 3 seconds for less than 10 years. And the plateau has to be seen on the FV in the volume time graph. So the inspection, the visual inspection of the graph gives you a lot of information. Then there are criteria for acceptability, which Dr. Bafna will talk about in the talk. So there have to be 3 acceptable maneuvers, right? And the upper limit is usually taken as 8, but it varies depending on the child. It might be less, it might be more, depending on the amount of fatigue which has set in. And then once you've got acceptable curves, you have to see whether they are actually reproducible or not, whether they are actually matching or not. And this is extremely important because sometimes you can really get fooled. The curve looks extremely normal, but the values are less, and the child does another one and the values are more, and that also looks normal in shape. So the reproducibility criteria are extremely important, and that you will learn once you do spirometries more. In preschool children between 4 and 6 years, spirometries are more challenging. The criteria are also slightly different. So back extrapolated volume of 10% is taken as the limit, or 75 ml. No specific duration of the end of test has been described as something like 3 seconds. At least 2 acceptable maneuvers. We don't have an upper limit for the test, again depending on fatigue. And for repeatability, it is taken as 100 ml or within 10% of each other. So with that, I would stop here and hand over to Dr. Rawat, sir. If there are any burning questions, then you can take them.
There is one question, Ankit sir, that if a child has expired for 2 seconds, can you take that as an valid effort?
See, that's what I was talking about, that, there are circumstances when you have to interpret a lung function. Okay. So you do a lung function in your clinic, in a hospital, and the child doesn't expire, right? So that is the most important error which happens in a pediatric spirometry. So you can very well, interpret that in the context. So what you need to understand is that supposing the child is blown out for 2 seconds, so your FEV1s are reliable, but your FVCs are underestimated. And in this situation, the FEV1 to FVC ratios will be erroneously high because the FVC is underestimated. So you can interpret it, but the interpretation has to be in this context. And whenever you're trying to report a lung function test, do make a cognizance of this fact that the FVCs seem to be underestimated, the FEV1 seem to be reliable, and this lung function has to be interpreted in the clinical setting.
Thank you. And there are a lot of questions regarding BEV, back extrapolated volume. People have not understood that particular term.
We'll be discussing that. We'll be discussing in the next session.
Okay, fine. And if the child is obese, like can you interpret the PFTs? One question is that regarding obesity.
Yes, absolutely. I don't think there are any different criteria for obese children, but yes, a lot of children with obesity is because of the fat around the chest wall. They can have some amount of restriction. That is something which we know. But I think the interpretation of PFTs remains the same. Obviously, you need to put in the correct weight of the child, the height of the child, to get the correct standards.
Okay, thank you. So we can take remaining in the open house and we can go for the next session. Dr. Tarika, please.
Yes, sir.
Sarika, do you want me to share the screen or you would be sharing?
Yes, sir. Please share the screen. Actually,
Okay.
here the network issue is there. That's why I'm not putting my video on.
Okay, I will share the screen.
Okay. Thank you, sir. So, first of all, I would like to thanks to the organizer for giving me the opportunity, and Bafna sir for helping me in drafting the presentation and guiding me. So, and Bafna sir and Dr. Ankit, they both had make my work very easy in their presentation, which was just discussed. So in my presentation, I have to discuss about the steps of the procedure of doing the spirometry. So as we are knowledgeable enough about the different terminologies related with the spirometry, we should also be aware that if the procedure is not done in the proper way, then all this practice will be waste. So procedure should be, spirometry procedure should be done in a correct way. Only then we can interpret it accordingly and answer our query as well as of the parents' query. So learning objective for this talk is what are the different type of spirometers?
Can you see the slides? Sarika, slides are visible, right?
Yes, sir. Yes, sir.
Okay.
Yes, sir. How to maintain, that is how we have to calibrate temperature, barometric pressure, other thing, the exact procedure of doing that. What is the bronchodilator response and what are the broncho provocation test? Few slides on that. Next, sir, please. Sorry. The next slide, please. So there are basically two type of spirometer. One is the volume displacement one, and another one is the flow sensor based one. And currently the mostly that one is used is the flow sensor based one. Next, sir, please. So the volume displacement manometer, here they function on this rolling piston method. So they have a water seal and rolling piston below, and the advantages use that they are very accurate, robust, and require minimum maintenance. However, the disadvantage with the volume-based spirometer is that they are bulky, not easily portable. Manual FEV1, FEC is there. No flow volume loop is there. No inspiratory loop is there. And no PFR and FEF 25-75% is there. So these are the big disadvantages associated with volume displacement spirometer, that they are not much in use, because as Dr. Ankit has already emphasized about the value of what is the force volume loop, how we can interpret on that basis, PFR, FEF 25-75, which is a very early parameter to be get disturbed in small airway obstructive diseases. And definitely we should have a spirometer that is portable, can be carried from here and there if we are planning to do spirometry in a camp and other area. So these are the disadvantages to be kept in mind while we are using volume displacement spirometer. Next, sir, please. Another one is the flow sensor based parameter. So they work on different mechanism by like the change in the pressure, by changing temperature, by changing the number of revolution, that is the turbine based, and the ultrasonic one where the ultrasonic transit time analysis is being used. So these are basically the technical detail. Whenever you are going to buy a spirometer, you should ask the company that which parameter, which mechanism it is working. They will also provide the information, and on that basis you will be aware that actually what is the basic parameter that is being used to have these spirometry value. Next, please. And how this flow sensor will measure volume. So they are the calibration. So one question is asked by Dr. Naresh that which type of spirometer is best. So as of now, the flow sensor one are the better than the volume one. So in the flow sensor, how it measures volume. So basically 1 liter per second into 5 seconds we multiply. And then that's how we calculate how much amount of volume of air have been blown. That is 5 liter. Next, sir, please. So after knowing that type of the spirometer, then another important thing is the how to maintain and calibrate. So as if that just making home is not enough, daily cleaning is essential to make a house home. So in the same way, a spirometer will work effectively only if we are aware of how to maintain it, how to calibrate it, which should be done daily. So the calibration, maintenance, and the infection control measure, which is very must for the proper functioning of the spirometer, they should be done as per the recommendation of the manufacturer. So you have to go through the booklet, the written material provided with the spirometer, and you have to interact with their engineers about all these things. And it is done daily with a 3-liter syringe. So this is the syringe which is used to calibrate. So many new generation spirometer now are available that do not require calibration daily or only after a certain number of the test, as used to be the case. But calibration is important. If calibration will not be done regularly, then the values given by the spirometer can be wrong over a time. Next, sir, please. So another thing is temperature correction, because we all know that the volume of air will be affected by the temperature. So this parameter should be presented at body temperature and ambient pressure saturated with water vapor. That is this word, short form you have seen on the different spirometry reading, that is BTPS. So the standard temperature, pressure, and the saturation with water vapor should be there maintained to have the value of the spirometry, because it is the last one, please. So as it is visible in this diagram that when the room temperature was 37, the same volume post vital capacity was 5.48 liter for a patient, but at a lower temperature this volume was reduced. So that's why the standard temperature need to be maintained. Next, sir, please. So before buying a spirometer, the point that should be in your mind, that should be checked, is that the equipment fulfill the recommendation of the American Thoracic Society or the European Respiratory System guideline, that it fulfill all that recommendation. The sensors and microprocessor unit quality should be checked. It should be checked for the portability, that whether the spirometer is portable or not. Then the report quality, the software, because now handheld spirometers are available where the software can be installed on your mobile, and other values can be there on your mobile, and you can show them to the parents, and a print hard copy can also be taken out. And definitely the cost is also important parameter. So these are the points to be taken in consideration when going to select a spirometer. Next, sir, please. Now, how to perform spirometry. So the basic procedure. Next, sir, please. So preparation. So before performing the spirometry, most important thing is the preparation. So preparation will be of the equipment, preparation will be of the patient itself. So as per the equipment preparation, we have to check whether it has been calibrated or not. Temperature, it is room temperature being maintained or not. We have to check with the thermohygrometer. Then we should have the salbutamol with a spacer to check for the bronchodilator reversibility. We should check that the computer and the printer are working properly or not, so that we have the hard copy of the spirometry parameters. Then patient. So we, before going for the procedure, we have to record the age, height, gender, and the race of the child. We have to ask about the activities, medication use, and relative contraindication. Activities like whether the child has just done exercise or not, had taken coffee or tea 1 hour before. Medication, that is the short-acting beta agonist, long-acting beta agonist, theophylline. It is like how many hours before they have taken these medication we have to check for, because if they are taken just within 1 hour 2 hour before that, it will affect the interpretation. And have the patient sitting comfortably in a chair. He should not have a heavy meal just before the procedure. So these are the different checklists which we have to ask the patient before performing the spirometry. Next, sir, please. And after we have checked the instrument and the patient, we have to instruct and demonstrate the test, because spirometry, we all know it is a procedure that the children feel like that it is very tedious job, and if a child is having obstruction, then this will become more problematic for them. So you have to demonstrate by doing procedure yourself. You have to use a spirometer with the some cartoon graphics being there on the spirometer, especially for the children, like blow the candle on the cake, or it is like taking out water from a well, Jack and Jill sort of. So some animation should also be used for the children so that they can do this procedure comfortably. Next, sir, please. So the medicines which need to be stopped and the duration. So if it is LABA, it should be stopped 24 hours before the procedure. The tiotropium should be stopped 36 to 48 hours before the procedure. Ipratropium 12 hours before. Short-acting beta agonist, that is salbutamol 6 hours before. And if there is availability of ultra lava, that is Valentrol, it should be stopped 36 hours before the procedure. As with inhaled corticosteroid, there is no guideline that they should be stopped. Inhaled corticosteroid can be given, but the beta agonists, whether short acting, long acting, and equilotropin, they should be stopped for a period of 6 hours to 36 hours, depending upon the type of chemical they are having. Next, sir, please. So the predicted values of the spirometry, it will depend upon age, height, gender, and race. So that's why before interpreting your value, you should note, you should check that whether these parameters have been entered in the spirometry machine or not. Next, sir, please. So now the maneuver. So how it is done. The most important thing is the posture. So as given in this diagram, the posture should be that the feet of the child should be comfortably on the ground. He should not struggle. He or she should not struggle to manage their feet on the ground. They should sit straight. And if it is, and the chair on which they are sitting, it should be adjustable as per the height of the child. So these are the important things, that the child must be sitting comfortably on a adjustable chair as per the height. Feet should be comfortably on the ground, and back should be straight. Sorry. So have patient assume the correct posture, attach nose clip on the nose and place mouthpiece in the mouth, and close lips around the mouth. So these are the first two steps. Then inspire, as Dr. Ankit had explained the procedure very correctly in the last presentation. So just to emphasize again, so inspire completely and rapidly with a pause of less than 2 seconds to total lung capacity. So before doing this procedure, you have to demonstrate to the parents and the child that, okay, sit comfortably, and when I will say breathe in, breathe in, breathe in, just breathe completely and rapidly. Next, sir, please. And then blow. So it is like after inspiration have been complete and rapid, just at the end of that inspiration, you have to give a clear and loud instruction that blow, 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 up to at least 3 seconds. So expire with maximal effort until no more air can be expelled, while maintaining an upright procedure. So as the question is also asked that how we will assess that the procedure has been performed correctly or not. So while we are instructing the child to do this maneuver, we will have an eye on the loop. So on the loop, we will see that there should be, it will be discussed later on that just at the end of the expiration, there is a steep and rapid rise in the expiratory maneuver up to the total lung capacity. And then when we say blow, 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 it should touch finally the this horizontal line. Up to that time, we have to say blow, 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 blow. Any procedure which is interrupted before that, it is not taken as the acceptable graph. We will discuss that also later. So expire with maximum effort until completely full. Next, sir, please. And repeat instruction as necessary. And we have to coach the child vigorously, because it is a procedure that can't be done in just one effort. So we have to repeat it again and again, and it should be repeated for a minimum of 3 maneuvers, and maximum is 8 for adult, because then the child or the adult will be fatigued. So if it is not being done properly, we have to repeat the procedure on another time. Next, sir, please. First, there is inspiration, then expiration. Dr. Archana. So check FEV1 and FVC repeatedly and perform more maneuver as necessary. Next, sir, please. And there should be no pause, no other cough, no exhalation through the nose piece, and blow is complete until exhale completely, which is suggested by plate 2 on the volume time graph. Next, sir, please. So this is the step. So as we say, patient, take a deep breath. So when we say take deep breath on this flow volume loop, we have no line being there. It is just when the patient, we are saying breathe in, breathe in, breathe in. Now take a deep breath. So up to this point, there is no curve or thing is happening on this flow volume loop. And as we say now blow. So as we say blow, so this phase 2 comes, that there is a rapid and sharp increase, sharp curves will happen. So this is blow. And when we say blow, 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 just as the phase 3 keep blowing. So this curve is coming up to the this thing horizontal line. So this is blow, 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 blow. And after that, in adults, it is recommended that again take a deep breath. But in pediatric age group, this parameter is shown in the step that is shown in the phase 4, that is take a deep breath again at the end of expiration, is not recommended. So in pediatric age group, first we say breathe in, breathe in, breathe in, breathe in. Now take a deep breath. So deep breath now, that is phase 1. At the end of that instruction, that is take a deep breath, we say blow. So that is phase 2. And then we say blow, 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 blow. This is phase 3, which we have to tell repeatedly up to this curve touches the horizontal line. And in pediatric age group, we do not do this phase 4 of taking a deep inhalation again at the end of expiration. So is it clear? First, we have to inspire deeply and maximally, followed by a rapid blow, that is expiration, and it has to be continued till 3 seconds. Inspiratory curve is not plotted. Yes, the next, please, this video. So as it is, as it was shown in the video, that the child was first asked to take a deep breath, and then was instructed to continue the expiration, and it was checked and the spirometry monitor for the pattern of the curve. So previous slide, please. Some people are asking. Video, sir. Yes, sir. So he's expiring continuously. Yes, here it is no nose clip. So although nose clip is recommended, but sometimes the child doesn't feel comfortable with that, so it is not used. So communication, So communication, pre-test, post-test communication is very needed. So pre-test, we should ensure that patient is sitting comfortably. We should try to eliminate the anxiety. We should demonstrate the test and ask for a repeat demonstration if they are not able to understand it properly. So these are the pre-test communication checklist. During the test, we have to constant reassure, because this is a procedure which is not being done in one or two steps. So a child may feel nervous that he is not able to do. So you have to assure, don't worry, just repeat it again. Constant cajoling and must not be written. So it should not be like the child will certain that some examination is going on, that we have to be scored on this. So we have to constantly reassure the child. So Dr. Sudhi, you asked that after touching baseline, should be asked to inspire. So in pediatric age group, it is not recommended to ask the child to inspire again at the end of expiration. Post-test, so after the test has been done, we have to check the graph for its acceptability and repeatability. And we should appreciate the effort given by the patient, which is an important thing, and repeat if necessary. So a positive feedback being given to the child will be very helpful to do the procedure. Next step, please. So now when to stop the test. So Dr. Mitesh is asking then how we will get inspiratory loop. So since the spirometry, basic use of it is for the disease like asthma, which is a disease of the expiratory loop. So we have to speak we have to focus on the expiratory loop only. That's why we do not go beyond the inspiratory loop. Inspiratory loop will be needed only in the condition of stridor being due to extrathoracic causes, where the inspiratory loop will be altered. So in only those conditions in pediatric, we need an inspiratory loop. So for maximum, that is for asthma, which is the maximum indication for pediatric spirometry, the inspiratory loop is not required. Clear? So now when to stop the test? So if there are 3 acceptable and 2 reproducible graphs, so that is the value of 2 graphs are within the 100 ml of the value of different parameters. So that is taken as the acceptable and the reproducible graph. Maximum 8 times we can perform the test. And at any time we should stop the procedure. If the child is feeling headache, lightheadedness, or fainting, then we have to stop the test and plan it on some another day. Next, please. So the criteria of a good quality graph on which we will check that whether it is acceptable or not. So acceptability criteria is that it should be good start. Good start is from the end of the expiration and at the start of expiration. When we say now take a now blow. So this is good start, and it should be a steep peak going up to the maximum, and followed by smooth and continuous descent. So during the descent part, there should the mouthpiece should not be clenched between the teeth. There should not be any cough at that time, and there should not be any early termination of the expiration. So this is the criteria of a good quality graph, that it looks like, if the inspiratory loop is complete, it looks like a boat shape, that is a triangle above and a semicircle below. But if it is just expiratory, so we have to look for the good start, we have to check for good peak, and for a smooth and continuous descent. If this is there, then it is the acceptable graph. So this was for the flow volume loop. For the volume versus time curve, it will take this shape, that is within first 2 seconds, the maximum FVC is almost reached, and after that it just plateau for the next 4 seconds. Next, please. So these are some of the artifacts. So just by looking at the loop only, you can find out whether this is acceptable or not. So as we discussed, so for the first one, so here there is not the continuous descent, which is interrupted in between by the cough. Next, please. So in this one, there is air leakage there. that initially it was not, there was not a this thing sharp and peak rise up to maximum. Next, sir, please. It is late start. Here, in the next, sir, please. Here the tongue is obstructing the mouthpiece, and this one, it is a poor effort. So just by looking at the graph, it is visible that these flow volume loops are not acceptable because there was not a good start, there was not a peak rise, there was not a smooth and continuous descent. So these are not the acceptable graph. So we will discard these uh, efforts and we will repeat again. Next, sir, please. Now, bronchodilator response system. So after you had done the first spirometry parameter, then we will give 4 puff of salbutamol and other 2 puff of ipratropium bromide to the child. Previous slide, please, sir. Dr. Vinod Uplankar is asking for. Yes, Dr. Vinod, what is your question on this? Or you just want to see this these loops?
ಸ್ವಲ್ಪ ಹೊತ್ತು ರೆಸ್ಟ್ ತಗೋ, ಹಾಡು ಗೀಡು ಹೇಳ್ಕೊ.
Next, sir, please. So bronchodilator response testing. So after we had done the pre-bronchodilator procedure, then we give the 4 puff of, although it is here written 2 to 4 puff, but for the normal, for a single value to be remembered, so 1 puff is equal to 100 micrograms. So we will give 4 puff, that is 400 micrograms of salbutamol, or 2 puff, that is 320 micrograms of ipratropium through the this thing mask and through the MDI spacer, and then we will record the post bronchodilator curve 15 minutes later for this thing is salbutamol and 30 minutes after for the ipratropium bromide. And if there is an increase in FEV1 of more than 12% or 200 ml from baseline, that it constitutes positive response. So as someone asked that bronchodilator need to be given to all or not, so let me tell you, since we are maximally use this spirometry procedure for the diagnosis of asthma, and in the diagnosis of asthma, post bronchodilator reversibility is the must. So that's why post bronchodilator response need to be done, and this dose is same irrespective of the age of the child. No, it is 12% or 1200 ml only. 8% response is not considered. So as till this slide discussion, we had seen that the shape of the flow volume loop is very important to find out the capacity of the child. So even if we are till now we had not reached up to the values of different parameters. So just by looking at the loop only, we can find out that whether obstruction is present or not. So here, look in this loop, that initially the pre-one, so pre-one is this black board line. So there was a sharp, good start, but the peak has not reached up to the normal value. It is terminating before, and Dr. Gitanjali, it is either of that for pediatric age group. And in the expiratory loop, there is concavity. Since asthma is the disease of obstruction in the expiratory limb only, so we are seeing the concavity of the descending loop. And after the bronchodilator was given, the loop has improved in height as well as in the transverse diameter. So just by looking at the loop, it is visible that the post bronchodilator reversibility was present. And we should also emphasize that although the loop improved, but it doesn't reach up to the normal curve, that which is the dot dash line, right? So early increase in FEV1 12% or 200 ml from baseline constitute a positive response, or 15 to 25% improvement if it is there in FEF 25 to 75. It also suggests a bronchodilator response. Next slide, please. And a negative bronchodilator reversibility test doesn't exclude the diagnosis of asthma, as it is a variable disease, because if the child is the asthma is now controlled, you are doing it in the phase of the remission, then it may be possible that the bronchodilator response is not there. But often asthma have a bronchodilator response. Next, please. So when there is dubiousity about the diagnosis of asthma, as someone asked in a question also that bronchodilator reversibility is not there, but the child is responding good to the ICS-LABA combination, then how we will check that whether it is asthma or not. So one test is bronchoprovocation test and another one is the Feno. So this is done to basically assess variable airflow limitation in airway hyper-responsiveness. So it is indicated and the clinical presentation is consistent with asthma, but a spirometry is normal and there is no bronchodilator response. So agents which are being used, some are direct and indirect. So the direct ones include methacholine, histamine, and the indirect and mannitol, and indirect one is the XSL. And as a precautionary measure, this should be done in a well-equipped facility with trained technician, because if it is like the severe bronchospasm happens, so there must be all the preparation being there to correct that bronchospasm. Since it is not, and this bronchoprovocation test is not done in the all the center. Very few centers used to do this bronchoprovocation test. Next, please. So the learning points are that we first have to select a spirometer which fulfill the ATS ERS recommendation. Proper technique is very important to have good quality spirogram, because only then we will be able to interpret the value correctly. Spirometry need good coaching, patience, and time, as it depends on child's efforts. Thank you.
Thank you, Dr. Sarika, for an excellent talk. I think that there is again some confusion regarding the sequence of respiration. Like you start with inspiration or expiration. To my request, again you explain the sequence of the test. When you start with inspiration or you start with expiration?
Yes, the test is started with inspiration only, but at the start of the test, this inspiration is not visible on the flow volume loop or the this thing flow versus volume versus time graph. So it need to be emphasized again that test start with inspiration. We give the instruction for first for tidal breathing, and then for the deep inspiration we give instruction breathe in, breathe out, breathe in, breathe out. Now take a deep breath. So up to this, so procedure had been started with inspiration, but up to this instruction, that is take a deep breath, this is not visible on the loop or the graph. At the end of inspiration, deep inspiration, we give instruction now blow. So when we say blow, then this appear on the flow volume loop as a good start with a sharp rise. And then we say blow, 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 blow. So while we give this instruction blow, 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 then the descending limb of the expiratory loop is being formed up till it touches the baseline. After that, in adults, we give instruction, now take a deep breath again. So then this downward loop of inspiration is completed in the form of a semicircle. In pediatric age group, we do not do this procedure of instructing inspiration again at the end of expiration. So is it clear now?
So again, there is one more interesting question asked, that we are trying to stress too much on the procedure, but there is a question that if a child has come to us with a spirometry report in which we have not observed how he has done, so would it be right to interpret the report? What do you say?
So if the procedure has been done correctly, then the loop will be formed correctly. So when the child comes with the report, we have to look at the loop, the characteristic of a acceptable one, that is there, the sharp start, good rise. There is a smooth and continual descent. So if it is not there, that means this is a not acceptable graph.
Thank you very much. I think, and apart from that, you have answered all the questions. Remaining we can take in the open house session. So I'll request Dr. Bhavna to start his next talk, please.
Okay, sir. Thank you, sir.
Thank you.
Thank you, Sarika and Dr. Rawat. Are my slides visible? Dr. Rawat,
Yes, sir.
slides?
Yes, sir.
Yeah.
Okay.
Yes, sir.
So, good afternoon and welcome back. So, after the interesting lectures by Dr. Ankit and Sarika, I think we have understood the basics of spirometry, and we also have understood how to perform a test. Now comes the most important step, and that is the interpretation of spirometry. And I would be taking you through this session, and I hope at the end of the session we are very confident to make an interpretation, right, correct interpretation of spirometry report, either done by us or it has been brought by the patient. So the learning objectives for this talk is, first and foremost, is we need to understand what do you mean by a good quality spirogram. There would be some repetition from earlier talks, but I think it is important because unless we have a good quality spirogram, there is no point in interpreting a graph. Then we'll look at the report. I think the spirometry report, like an ECG report, many times we get frightened. Oh, it is showing so many figures and loops, and what do I make out of this? We will try to simplify it for you so that it becomes easy for you to understand the components of the report. And once we are familiar with the components of the report, we will try to discuss what do you make out of the figures and the graph, and how do we make a final assessment about the type of pulmonary dysfunction, and lastly, how do we grade the severity of obstruction. So in any interpretation, whether it is a clinical interpretation of an investigation, we have to be methodical. If we follow the methodical approach, then I think it is very simple and it is very easy, because then we remember and we do not miss anything. So the first step has been discussed again and again by the previous speakers, is check for acceptability and repeatability, because beyond this, if we go, if the graph is not acceptable and repeatable, then further exercise is futile. The next step is look at the loops and graphs. Then we look at the figures and we compare these figures with the normal or reference values. And depending on our assessment of loops and figures, now we come to the conclusion about the type of pulmonary dysfunction. And as we said, we can say that this is an obstructive pattern, this is a restrictive pattern, or a mixed pattern. Obviously, there is a possibility that spirometry may be normal also. And once we have decided that this is this abnormal pattern, the last step is to grade what is the actual severity of dysfunction, particularly of an obstructive disease. So as I said, there may be some repetition, but this is the most important step, and therefore I think it is better to revise the acceptability and repeatability criteria. A good quality spirometer is the one where you have 3 acceptable graphs and 2 reproducible graphs. What do you mean by acceptability? Acceptability is how has the child performed the test. What is, as was discussed by Sarika, whether he has done all the steps correctly. So it's a within the manual evaluation of individual trials. What do you mean by repeatability? Repeatability is if you keep repeating the trial in that child, you will get the same result. That means you must have the values which are falling close to each other. So at least two reproducible graphs should be there. So three acceptable and two reproducible. Until you get those reports, trials, you need to keep repeating the test. Of course, maximum is up to 8 or before that if the child is fatigued. So these are the guidelines. As per the ATS guidelines, you need to have those many graphs. This was shown by Sarika and beautifully explained that you need to have a good start. The child should blow hard, so there is a continuous maximal effort to achieve a good peak, and there is a continuous smooth exhalation without artifacts, and there shouldn't be an abrupt termination. So as was asked, first he's taken a deep breath, which is not documented on this graph. Then he started expiring, exhaling, there is a peak, and then there is a descent. And if you have done inspiration, deep inspiration, then you will get this inspiratory loop. So this was like, broadly, you should have a good start, you should have a good maximal effort, no artifacts, and good end. And why are you focusing so much on acceptability? Because spirometry is an effort dependent test, and we need to have the best value of the patient. The patient is not putting an effort, his FEV1 and FEC will be low, and we may make an erroneous diagnosis. Therefore, it is important that we make sure that the effort put by the patients are the best. Now, another important thing is most of the spirometers will do this automatically. So don't worry that I have to look for these values, criteria. These criteria are for us to understand the basics, because as I said, we want you to do the spirometry. So you must know how machine has actually interpreted that this is an acceptable graph. So you will, when you are doing a spirometry, it will show you now till now 2 acceptable graphs, 1 acceptable graph, 3 acceptable graph, or 1 reproducible. So don't worry, it will be automatically done by the new generation machines, but you must know the basis of this criteria. So as we said, we will go slightly in detail about the acceptability criteria. So there should be a maximal inspiration at the start of manual. Very simple to understand. Unless you take a deep breath to TLC, whatever volume is coming out will be less. So if you have not taken a deep inspiration, your FEC will be low. So therefore, child, the adult has to take a deep inspiration to TLC and then starts exhaling. How do you know that he has taken a deep breath? What is the criteria which machine is going to utilize? So as we said, he takes a deep breath, then he exhales, and there may be an inspiratory loop where he takes a deep breath again. So that last deep breath is giving you inspiratory vital capacity, and the expiration is giving you expiratory vital capacity. So if this difference between expiratory and inspiratory vital capacity is less than 100, then you are sure that he had initially also taken a deep breath and the expiratory vital capacity is equal. So that's that criteria which is actually calculated by the machine. Second important point is, after child has taken a deep breath, he should start exhaling immediately without a pause, and he should start exhaling with a force. And how do we know that there was no pause? Now, you know that many children will take a deep inspiration, they may pause and start exhaling. But we must have the time point where he actually started exhaling, and that is known as a time zero. And we will discuss time zero and back extrapolated volume in next slide. But at this point, just remember that after a deep inspiration, the exhalation should start immediately without a long pause. Then, as we said, unless you have a satisfactory exhalation, your FEC will again be affected. So good start means sudden rise to the peak. If it is not there, your FEV1 will be affected. If child has not taken continuous smooth exhalation, your FVC will be affected, because if you abruptly terminate the maneuver, then your FVC will be low. Now, how do we know that the exhalation was satisfactory? As we saw in the slide also, in the video also, and in the graph, as child starts exhaling, within few seconds, maybe 3 to 6 seconds, the volume time curve will show you the plateau. So it will reach a plateau. That means even if he's continuously exhaling, no more air is coming out. So if he has reached a plateau which is visible, and in figure terms, if no more air, that is not more than 25 ml of air is coming out now in last second, then we are sure that exhalation was complete. Another way, of course, is expiratory time. If the child or the adult has exhaled for 15 seconds, which is impossible to do, definitely not possible in children, then that is one of the criteria. And lastly, if the child's FVC, you know that he has achieved a good FVC, which is comparable to the earlier or the next FVC, then you know that exhalation is complete. So to remember this, you must remember that child must exhale completely, and you should see a good plateau, and at least a minimum 3 to 6 seconds of exhalation would achieve that. And of course, your graph should be free from artifacts, which has been beautifully discussed. There shouldn't be any cough, closure, leak, or obstruction of the mouthpiece. Now, just 30 seconds for this slide. We said that it should be a good start. Now, what do you mean by this? So the child has taken a deep breath and he starts exhaling here. Please focus on this x-axis from -1 to 0. He has taken a deep breath, and now there is a small pause, milliseconds of pause, and he started exhaling. Suppose he takes a longer pause. Whatever time the child has started exhaling, your time 0 will start, and that will calculate first second. That is, FEV1 is the volume exhaled in first second. So suppose child has taken a pause, then your FEV1 will become low because he's not done maximum exhalation. To correct for that, machine will calculate time 0 by back extrapolation method. So what is done is this vertical line, the orange line is drawn through the peak of time volume curve, and where it intersects x-axis, that is actually taken as time 0. And therefore your FEV1 is actually calculated from the point where actually the child started exhaling well, and therefore your FEV1 will be the correct one. I hope this is understood, but there is some problem in this. There is a possibility that child has exhaled a bit amount of air and then the time 0 has started. So as long as, so that volume of air which child has exhaled before time 0 is known as back extrapolated volume, and this back extrapolated volume is also included in FEV1. So you can understand that if the pause is small and the back extrapolated volume is less, then it will not matter much. In the first slide, you can see that the pause is very small and the back extrapolated volume is very less, and it will not give you erroneously high FEV1. But in the second graph, you can see that the pause is longer before time 0. There is some volume which has already child has exhaled, which is included in FEV1. So now, since the pause was longer, BEV is longer, and FEV1 will be erroneously high. And therefore, the criteria is your back extrapolated volume should not be more than 5% of FVC, or should not be more than 100 ml. So I think, again, as I told you, this will be calculated by machine. You need to understand the simple important concept. As soon as the child has taken a deep breath, without taking a pause, he should start exhaling. If the pause is longer, your back extrapolated volume and FEV1 will be erroneously high. I hope this is clear. We can go to the next thing, which is reversibility criteria. Again, explain that FVC and FEV1 the difference between two largest FVC and FEV1 should not be more than 150. So if you have one trial which is showing 1.55 liter and another trial it is showing 1.85 liter, that is 300 ml of difference. That means we don't know actually the FVC is could be much higher. It may be more than 185 also. So you don't know whether the child is putting in a good effort. So you will have to keep on doing the test again and again, because you want to know the best FVC for that child or best FEV1 for the child. For age less than 6 years, the FVC and FEV1, they should be comparable. The difference should not be more than 100 ml. So if one trial is showing 1 liter and other trial is showing 1.1 liter, that is acceptable. But if it is more than 100 ml or more than 10% of FVC value, then again it does not fulfill the criteria. So simple thing, your FEV1 and FVC value from two acceptable trials must fall within 150 ml of each other. That is for above 6 years, and between less than 6 years it is 100 ml. So once we are sure that the trials are acceptable and there are reproducible trial, another important point which I would like to make here is about, somebody asked if the patient has come with the report, how do we know? Now, the new generation spirometers will actually put the quality analysis of that trial. So the spirometry report will also show you that it is A, B, C, D. So it is graded. The spirometry is graded as A, that is the best, that is the highest quality. You have 3 acceptable and 2 reproducible graph. If there is some problem, then it is graded as B, then C, and then D. So D is the lowest quality. So you would know from the loops and also from the quality which is graded according to the machine, that whether it is acceptable or not. Next is, let's look at the components of this spirometry report. Now, just a minute. So this is how the spirometry report will look like, and so the first part will show you the patient information, the name of the patient, height is most important, age, sex, and the ethnicity is most important because values would depend upon the ethnicity. Then what type of test you have done, and this is showing interpretation gold. Gold is, you know that the quality of the spirometry is very good, and the various which predicted values you have used. Polgar is the ERS reference standard. Then the second component is showing the figures, and the third part of the graph, the spirometry, is showing the graph loops and graphs. Of course, this can be customized whatever you want. You want only one trial, you want all the trials, everything can be customized. So this is how the spirometry report would look like. So there are two components, as we said, graphs and figures, and the two graphs which are volume time and flow volume loop, and figures basically are telling you about the volume and flow. So this was beautifully explained by Ankit. This is your flow volume loop. Now let's, the next step, as we said, the third step is, of course, the second step is to look at the loops and graphs. So let's look at the flow volume loop. This was the flow volume loop discussed by Ankit. So how do we interpret the flow volume loop? Normal flow volume loop looks like a cell which rises sharply to a peak and then descends at an angle of 45 degrees. In a child who has obstruction, there is a scooping or sagging appearance to the flow volume loop. And as more and more obstruction or obstructive disease progresses, this scooping will increase and the loop will become more and more concave. Whereas in a child who has a restrictive disease, which is not very common situation, since airflow and lung volume are reduced proportionately, what you get is a normal curve but a smaller curve, because lung volume is also low, therefore FEV1 will also go down, but the loop will be normal but smaller. So merely looking at the loop, you get a lot of idea about what type of patient you are dealing with. So this is how, looking at the graph, you can make out. So this is the normal flow volume loop. In the initial part of the obstructive airway disease, as we know, it will affect only the distal smaller airways, and therefore the flow is normal in most of the flow volume loop. Only the terminal portion of flow volume loop is showing slight flattening, and as the obstruction progresses, you will see that more and more scooping is occurring, because higher and higher, at the higher level of volume expiration, you are getting flow limitation. So flow will become smaller and smaller, or lower and lower. And in the, as you can see, in the mild obstruction, even the peak is normal, but as the obstruction progresses, your peak flow has also go down. So your peak flow has gone down, and the graph will appear more and more scooped. Now this was a volume type curve which was discussed, and normally it would look like a, a sharp rise and then a plateau, which you should look when the child is performing spirometry. In an obstructed child, this rise will not be sharp. He will not able to exhale fast with force, and he will exhale slowly. There will be a gradual rise, and the plateau will be reached slowly, as you can see in this graph. Now, as you can see in the first white graph, this is the normal rise, and within few seconds there is no more air coming, so you know that the expiration is complete. As there is a mild obstruction, child is not able to blow so hard, so his FEV1 goes down, but he will still complete the maneuver, and at the end of maybe slightly longer time, his FVC, he will able to breathe out. The FVC is still normal. In a moderate obstruction, again FEV1 has gone down, but still he has reached his FVC. Slowly he will empty the lungs. Only in very severe obstruction you can see that his FE1 has gone down, and even after 6 seconds or a longer period of time, he is not able to blow out the complete FVC, and therefore in this situation your FEV1 and FVC both will go down. So now, after understanding or looking at the graphs, we have got a fair idea whether we are dealing with obstructive or restrictive problem. Let's look at the figures now, or try to understand how do we interpret figures in a stepwise manner. So this is the part of the spirometer or spirometry report, which is showing you various figures. Don't get scared or bogged down by the number of figures. I will just try to dissect each and every component. So this is the first table, which is showing various parameters, and essentially we just need to remember three parameters, that is the ratio, FEV1 FVC ratio, FVC, and the bronchodilator response. That is all, and then of course lastly FEV1. So you don't have to worry that there are so many parameters. So these are the important parameters which are seen. You have FVC, FEV1, the ratio, FEF 2575, peak expiratory flow, the force expiratory time, how much time the child has blown, and FIVC if you have done the inspiratory maneuver. So that's how it will show. Then you have a second component, or the second table, which is showing the predicted values or lower limit of normal. Predicted value is basically the 50th percentile values for that age, sex, and ethnicity. This is the values which are there. These are the predicted values against which we are going to compare patient values. Now patient has performed, as you can see, 3 acceptable trials, and the machine has chosen the best trial, and this is again done by machine. So this is the best value which you have got. So these are the pre-base, that is before giving a bronchodilator, these are the values of the patient. Now we have to compare these values with the predicted values. So this is the table which shows patient value which are presented as percentage predicted. Very simple to understand. Suppose the predicted value is 1 liter of FVC and the patient value is 900 ml, that is 0.9 liter, then the percent predicted will be 90%. If the patient predicted value for FEV1 is say 2 liter and the patient value is 1.6 liter, then it becomes 80% of the predicted. So that's how the percent predicted is reported here, because your interpretation is basically dependent on percent predicted. And as Ankit has said, we can also interpret from the Z score. So less than 2 Z score or minus 2 Z score is taken as abnormal. Then we have another column here, same thing which is repeated after giving bronchodilator after 15 minutes, and same things you get the patient value again, the best values, various trials, percent predicted, and more importantly, we are now interested only in one thing. This is the change, percentage change from the pre to post. So what is the percentage change which has occurred, particularly in FEV1? So we are only interested in percentage change of FEV1, and anything about 12% and 200 ml is taken as positive value. You can also look at F25 change, which is taken as around 25% is taken as a positive change. So these two values we are going to look after the bronchodilator, and we will assess whether there is a bronchodilator response. Now, what is percentage change? For example, in a pre test, the patient's FEV1 is 1 liter. And if it has increased to 1.2 liter, then the percentage change is 20%. That's how it is calculated. Very, very simple. So I hope this figure table is understood. Now we'll go to the next step, that is what do we make out of these figures. As I said, there will be a lot of figures. Actually, you can customize to your own comfort. Only two volumes which we are interested is FVC, FEV1 and their ratio. Two flows which are important for us are peak expiratory flow and FEF 2575, and they are reported as, first of course, what are the predicted values, what is the patient value, and patient value which is presented as a percentage of the predicted value. And then of course these values are reported as before bronchodilator and after bronchodilator. So this is how the parameters you need to remember. Only 4 parameters in fact you need to remember. So again, we are going to look at the ratio, then we are going to look at the FVC percentage, and of course FEF 2575, and what is the change in FEV1. So it is so simple. You just have to look at the ratio, then look at FVC, and then decide whether you are obstructive or restrictive, then look at the percentage change and decide whether there is a bronchodilator response. It is so simple. So you don't have to worry about the so many figures there. So what do you mean by predicted values, normal values, or reference values? What is taken as normal? We must know normal before we say what is abnormal. So patient value, as we said, is compared with predicted value and then is presented as percent predicted. Now, anything which is above 80% of predicted value is taken as normal. So FEV1, which is above 80%, or FVC above 80% is taken as normal. Ratio also, if it is above 80% or above lower limit of normal, then it is taken as normal. We can also use Z scores to look at FEV1 and FVC. As I said, 2 standard deviation is taken as abnormal. So usually in practice we use 80% of predicted. So if you have values of the ratio which is less than 80% or less than lower limit of normal, the child has abnormal ratio. If FVC is low, then the child has low FVC, and the FEV1 is less than 80%, then it is abnormal. So that's how then we will interpret. Just a small slide about how are these reference values derived. Now, ideally, these reference values are derived or calculated with equations derived from measurements observed in representative sample, like a growth chart. So you have height and weight for Indian population, for Maharashtrian children, for North Indian children, something like that. These FEV1, FVC, the ratio, everything is calculated for that ethnic population ideally. So you should have same age, race, sex, and then the percentile charts are drawn. And from that percentile charts, you will know less than 5th percentile is usually taken as lower limit of normal, or the mean 50th percentile is the predicted value. However, unfortunately, these charts may not be available for each and every ethnic population. For example, we do not have robust data of spirometry for Indian children. So then if they are not available, then what do? Then you use some data which is available and make a adjustment factor which is used. So for example, we use Caucasian data, that Polgar is a ERS standard, and there has to be some correction factor which is used, because our lung volumes, our FEV1 may be lesser than Caucasian population. Therefore, we use a correction factor of 0.94, which is again fed in the machine itself. You don't have to do anything, but this is how it is machine calculated. So when you buy a machine, you should ask them which reference values are there in this machine, and you have to select Asian when you are selecting or filling the data of the patient. Recently, ERS has published the global multi-ethnic lung function for spirometry for children between 3 to 95 years of range. So right now, we are using European data, Polgar data, and as we can shift to this ERS data also. Now, so we have said that the child's FEV1, FVC, and the ratio is either normal or abnormal. If it is abnormal, then we need to know what is the type of dysfunction we are contemplating in that patient. So let's look at what happens in an obstructive disease to various figures. We are talking of figures now. So as we said, in an obstructive airway disease, what is affected is flow. Volume gets affected only in severe obstructions. So what is happen? The FEV1 is much lesser, but FVC would remain normal. Obviously, if FEV1 goes down and FVC is normal, your ratio will go down. That is, in FEV1, FVC will be less than 80% with normal FVC. So what do you get in obstructive airway disease? You have decreased FEV1 by FVC, but normal FVC. In a very, very severe obstruction, as we said, FVC will maybe affected, but we can forget that for the timing and remember that low FVC and low ratio and normal FVC is obstructive. Then, of course, FEV1 will be less than 80%, and your FEF 2575 will also be less than 65%. As Ankit said, it's a variable parameter, may not be reproducible. So if everything is normal and there is a strong history, and if this is less than 65, you can say that yes, there is a small airway disease. Bronchodilator response is assessed by looking at FEV1, and change in FEV1 should be more than 12%. What will happen to various figures in restrictive lung disease? Now, in restrictive lung disease, flow is normal, but your lung volume has gone down. Because the lung volume, the FVC has gone down, obviously the FEV1 which is coming out in first second will also be low, though the flow is normal. So there is a proportionate decrease in FEV1 and FVC, and therefore the ratio will remain unchanged or even increase, because FEV1 may be normal, FVC is low, so you may have an increased ratio or a normal ratio. So what will happen to your FeV1 by FVC ratio? Either it is normal or increase. Your FVC definitely is gone down, which is less than 80%, and your FeV1 may be normal or slightly decreased. In a mixed disorder, you have obstruction and restriction both, cystic fibrosis, bronchiectasis, bronchiolitis obliterans. What is going to happen? And severe asthma, of course. All the parameters will go down. So if you have a child whose FeV1, FVC is low, his FVC is low, and FeV1 is low, you are dealing with a mixed disorder. But important thing about this restrictive lung disease, you must remember, is the most common cause of restrictive lung disease reported automatically by the computer is a poor effort. If the child has not taken a deep breath or he is not exhaled for a longer duration of time, your FVC will be low. So your ratio may be normal, FVC is low, and computer will say restrictive lung disease. So that's why you need to manually report the data. So in nutshell, in an obstructive disease, your ratio goes down, FVC remains normal, and your FEV1 is low. FEV1, we only look for grading. For the diagnosis, it is just the ratio and FVC. In a restrictive disease, the ratio remains normal or increase, and FVC goes down. If you look at FEV1, it may be normal or decrease. In a mixed disorder, everything goes down. So you must remember this table correctly. In an obstruction, ratio goes down, FVC is normal. In restriction, ratio is normal, but FVC goes down. And in a mixed disorder, both ratio and FVC is down. So we are coming to the end of the talk. What have we learned? So first, of course, you feel the demographic details, very important to know what is the type of patient, Asian patient, Caucasian patient. So you must feel the details properly. Height is very important. Then look at the flow volume loop and volume time graph for acceptability and repeatability. That is your first step. Once you have confirmed and also looked at the flow volume loop for any evidence of obstruction or restriction, go to the values. Only after you have looked at the loops, go to the values. In values, as we said, only first step is look at the ratio, FeV1 by FVC ratio. Now, if my ratio is reduced, then I will look at, of course, the next step is look at FVC percentage. As we said, 80% you have to blanketly remember. So your FVC is also reduced. I'm sorry, if your FVC is normal, then you are dealing with obstructive airway disease. So your ratio is reduced, but your FVC is normal. This is an obstructive airway disease. And the next step will be to give a bronchodilator, to look at the post bronchodilator response. So if your now you are looking at FEV1, whether the FEV1 has gone down or increased by 12%, then you know that there is a positive bronchodilator response. So then you can confirm the diagnosis of obstructive airway disease. Then you also look at FEV1 to grade the degree of obstruction. Now, if your ratio is reduced and your FVC is also reduced, then we said ratio is low and FVC is also low. Either you are dealing with mixed obstruction, mixed type of abnormality, or as we said, in severe obstruction, both will go down. Again, you look at the reversibility. If there is a reversibility, probably you are dealing with severe obstruction. If not, then it could be a mixed disorder. And also you need to take into clinical context into consideration. And of course, you would need further test if you are suspecting a mixed disease or restrictive disease. Now come to this part of the graph. If your ratio is normal, again, you have looked at FVC. If FVC is also normal, the child has no abnormality as far as the spirometry is concerned. So you can report that the spirometry is normal. Of course, there shouldn't be a bronchodilator response. It can happen that everything is normal, but there is a bronchodilator response. again, that means that there is definitely obstructive disease. It can happen if your FEV1 could be low and there is a bronchodilator response. In that case, it is an obstructive disease. If your ratio is normal and FVC is reduced, very simple, it is a restrictive lung disease. But as has been pointed out, spirometry is a test which is performed for obstructive disease. For a restrictive disease, it is a screening test. It may give you an idea that it is possibly a restrictive disease. Go ahead and do body box or body plethysmography and DLCO if the child is older to find out the type of restrictive lung, confirm the restrictive lung disease and the type. So if, and of course, as I told you, you have to be very sure that the efforts were good and FVC is not low because the efforts were poor. So this is in nutshell how you are going to do. So only two values, again to repeat, the ratio and FVC. That's all you need to remember to decide whether it is restriction or obstruction. Then you go back to the bronchodilator response and then look at the FVC, FEV1. So I will just, we'll go through this. This is the figure. First look at the ratio, which is normal, 90%. Then look at FVC, which is also normal. FEV1, of course, you look at the FEV1 25-75, which is 84%, which is normal. There is no bronchodilator response, and your FEV1 is 88. So this was a normal spirometry. In this child, first look at the ratio, which is 70%. The next step is look at the FVC, which is 101%, 70% is low. So low ratio, normal FVC, we have made the diagnosis of obstructive airway disease. Now, of course, also look at the FEF 25-75, which is 39%, which is again low. Now you look at the bronchodilator response, which is 21%. So it confirms the diagnosis of obstructive airway disease. So as I said, we have just looked at two figures, the ratio and FVC, and made a provisional assessment that this is an obstruction. Then you look at the bronchodilator response, which is 21%. You confirm that this is obstructive airway disease. Now you want to know how severe is the obstruction. Look at the FEV1. So until last, you are not looking at FEV1 actually. So this is a mild obstructive airway disease. Why mild? Because FEV1 is 75 and there is a good bronchodilator response. That's how you are going to report. So how do you assess the degree of obstruction? This is for adults. So anything above between 70 to 80, FEV1 70 to 80 is mild. Just remember 50 to 70 is moderate and less than 50 is severe. So 50 to 70, above 70 and less than 50. For children, it is above 80, 50 to 80 and less than 50. So this is as per the 2005 guidelines. So you can assess the degree of obstruction as per this chart. As we said, severity can also be assessed by looking at the graph. This is the normal graph. This is mild obstruction because it is more or less a normal flow volume loop. At the terminal part, there is some flattening. There is a concavity which is occurring, and in the orange graph, even the peak has gone down and the concavity is much less, now much more severe. So last part of the talk, as we were, I think there were a lot of questions whether we should do an inspiratory loop. As Sarika was saying, for diagnosis of asthma, only expiratory loop is fine. But to complete the spirometry, even if you do inspiratory loop, it will complete the spirometry. You can do it, adults definitely. In children also, we do it because it may give you a clue about central airway obstruction. As Sarika told you, that some children who have extrathoracic or intrathoracic central airway obstruction, your inspiratory loop is vital. So not in all children, but definitely in asthma, it may not be useful, but to complete the spirometry report or to get a good information, it's better to perform the inspiratory loop as well. So look at this graph. As you see, you can see that this is an expiratory loop which is flattened, and this is the inspiratory loop, which is normal. So expiratory loop is smaller than inspiratory loop. So that means there is something which is variable obstruction, and this type of loop you can get in a central airway obstruction. In a peripheral obstruction or asthma, you will get equal loops, as we have discussed. So this is variable, and since, as we know, expiratory loop is affected, that is, obstruction is more in expiration, therefore it is intrathoracic. We all know by our physiology that is expiratory obstruction or intrathoracic problem will give rise to expiratory obstruction, and extrathoracic will give rise to inspiratory obstruction. Now in this graph, as you can see, the expiratory loop is normal and the inspiratory loop is affected. That means again there is a variable obstruction. It is more likely to be central airway obstruction. Central airway means by larynx and trachea and maybe major bronchi. Since it is inspiratory more than expiratory, it is more likely to be extrathoracic. So it is variable extrathoracic central airway obstruction. Conditions like vocal cord palsy, vocal cord dysfunction, laryngomalacia will give rise to this type of picture. Intrathoracic variable obstruction may be bronchomalacia, tracheomalacia. Now in this graph, you can see that inspiratory and expiratory loop both are flattened. That means it is a fixed obstruction. It's not variable obstruction. Both inspiration and expiration are affected. It may be intrathoracic, it may be extrathoracic, but during both inspiration and expiration, child is having problem. The inspiration is affected equally and expiration is also, there is an obstruction during expiration as well. So this is a fixed central airway obstruction. It can be extrathoracic like subglottic stenosis, or it may be intrathoracic like something pressing on the trachea, intrathoracic trachea like a tumor. So this is an additional benefit of doing a spirometry. Of course, the main purpose of doing a spirometry is for obstructive airway disease like asthma. But if you have performed the inspiratory loop, this information is available to you. So friends, to summarize, first step in interpreting spirometry is look at the acceptability and reproducibility, and that's why I think we spent a slightly more time in discussing this, because this is the most important and crucial step. Quality is most important, because when you send most of us do our spirometry on our own, because if you send to a technician, they will probably do it in a hurry, they will not explain, and many times even the reproducibility, somebody said there is no reproducibility, they will give a inhaler, maybe the technique may be wrong, and after 5-10 minutes they would perform the test. You will not get the reproducibility because all these steps are not followed. So it is very important to perform the test properly, because it is a examiner or the performer based test, as well as the test which is based on the who is performing the test, or on the child and as well as the technician. Now inspection of graphs is the first step, which gives you valuable information. Then you look at the figures, and the only two figures which essentially in the initial part you need to remember is the ratio and FVC. That's all you need to remember initially. Then you need to look at the bronchodilator response and the severity grading, that is FEV1. So I think very simple. Just look at the ratio and FVC, remember the table, and you can come to a conclusion whether it is obstruction or restriction. Then you go ahead and look at FEV1, what is the reversibility and severity of the disease. Thank you so much. Thank you for your patient hearing, and I would be very happy to answer any questions.
Thank you, Dr. Bapna. We are running about half an hour late, so we would take the open house session where we will answer all the questions. Then we will straight away take the session of Dr. Pawan Kalyan.
No problem.
I think that will be fine.
Yeah, sure.
So I'll first take the Q&A box. Is there any role of CT scan for checking restrictive lung disease in children below 5 years?
Yes, obviously. So there is no question that CT scan is vital and most important for diagnosis if you are suspecting a restrictive lung disease, like anything like a bronchiolitis obliterans, hypersensitive pneumonitis, so any cystic fibrosis, so any restrictive lung disease, CT scan is vital because this will give you an idea about structural abnormality and parenchymal situation.
A 10-year-old child is having clinical features suggestive of asthma. History of allergic rhinitis is there, and spirometry is showing obstructive changes without significant bronchodilator reversibility. But patient is showing a good improvement on formoterol budesonide. What should be done in this case?
Yes, so I think as we discussed, most important is whether the spirometry was performed correctly, and if it is showing an obstructive pattern and there is no response, whether the MDIs were given correctly, whether we had waited for 15 minutes, that all has to be done. Despite of the proper technique, if there is no reversibility, there is a possibility that the child is already on budesonide and formoterol, and therefore he may not show much response. But if clinically, as we said, clinically, if the child is showing a response, there is an allergic rhinitis, there is definitely a phenotype of atopy, you should continue to give him foracort and budesonide and follow this child and maybe perform a spirometry later again.
There are some question about the cost of spirometer. So what is an average cost of a
average cost of spirometer is around whatever we are using. We will not take any brand names, but they are between 1 to 1.5 lakhs in the office practice, for office practice, not for hospital use.
Okay.
These are the flow sensor based ultrasonic spirometers which are available. They are very handy, portable, and very easy to use.
In a child with ascending paralysis like GPS, what bedside test can be done to find out impending paralysis of respiratory muscle?
I think it is a clinical diagnosis. So because if it is an ascending paralysis, I don't think you need to perform any pulmonary function test. It's basically your clinical acumen, monitoring respiratory rate and single breath count and looking at saturation. That's all is going to help.
Okay.
Yes, and apart from that, although the literature maintained that we should measure the peak cough pressure, sneeze pressure, these are the diaphragmatic activity by ultrasound. These are the theoretical possibility which are being done in Western country, not done in our country. So as Dr. Bapna sir has said, so that just by clinical diagnosis and looking at the chest expansion, we should look at the muscles power.
So muscle power, as we said, can be tested by doing a maximum inspiratory and maximum expiratory test, which is not available. So I don't think it is.
Yes, it is not available here.
If FEV1 is less than 80% and FEV1 upon FVC is normal and not able to get reversibility, still clinically look like asthma, so shall we proceed with trial of ICS?
Can you repeat that question?
While doing spirometry, if FEV1 is less than 80% and FEV1 upon FVC was normal and not able to get reversibility, and clinically the doctor is sure it is asthma, so should we proceed with the trial of ICS?
Okay, so the trial of ICS, of course, the one area where trial of ICS is definitely recommended is preschool visa, where you have a clinical context and you will give a trial and stop the ICS. In those patients where you have again, you will go by the clinic, in an older child, you will go by clinical history, documented V's, asthma-like phenotype, history of atopy. Spirometry is one of the supportive tests. It is not the test that it will rule out asthma. Definitely, it will rule in asthma. So I think if clinical suspicion is very high, trial is recommended, and follow-up of the patient on clinical and spirometric is what I would do in these patients.
And
of course, you can use other tests.
Question, because he has mentioned that there is low FEV1 but normal FEV1 FVC. It is not possible. If you have got a low FEV1, definitely this ratio would be low. So I think this question looks more critical.
No,
And
so I think just
Okay.
to add one thing here, this usually happens in pediatric spirometries when the FVC is underestimated because of a effort which has been terminated early. So we are saying that the FEV1 is reliable because the start and the initial part of the test was done fine, but the child just suddenly stops to breathe. And that leads to a blow of 1 or 2 seconds. It is at least 1 second because you are getting the FEV1s, but your FVCs get underestimated. So look at the volume time graph. see for how much seconds the child has expired. And you need to note that in such situations, anyone who interprets the test or anyone who reports the test should report that the FVC was underestimated, and hence the ratios can be abnormally high, which they should not be.
Moreover, this presentation that FEV1 less than 80% ratio is normal and the child is asthmatic, there is no this in bronchodilator reversibility. So often we should also have some other answers to it, like what is the age of the child, for how many years he is asthmatic, controlled, uncontrolled, number of exacerbation, because often it happened in a person who is a little bit older, who is having uncontrolled asthma on not a regular controller medication. When the overlap between asthma and COPD happened, then this bronchodilator reversibility is lost. It is going into fixed airway obstruction. And in that condition, because of expiratory hold of the air, FVC is also reduced. So the ratio become normal and FEV1 is less than 80% and there is no bronchodilator reversibility. So definitely ICS need to be given in that person, but that need to be educated repeatedly about being compliant with the drug, so that there is no further deterioration in his or her respiratory function, which is already here, that the asthma is now going into fixed airway obstruction pattern.
Absolutely correct. So I think it is very clear from Dr. Bhavna is that as you start inputting the report, the first thing we should see is the ratio FE1 FVC. Because if that ratio is normal, then everything, probably you are not dealing with an obstructive airway disease. So I think instead of trying to see FEV1 first you should go into the order which Dr. Bhavna has mentioned. First is the ratio. If the ratio is normal, then probably you think that there is something wrong in the effort or everything, whatever it may be. So I think you go methodical whenever you interpret a fundamental report. Always remember the order in which you have to see the interpretation. Then the question was, how does tea and coffee drink affect spirometry? How does tea and coffee intake would affect spirometry?
Because of the presence of caffeine in them, which acts as a bit bronchodilator. So not very much like a bronchodilator, but because of that presence of that chemical, it affects. So that's why these are avoided.
Okay, if a child is having pleurisy or any painful condition of chest, can you do spirometry?
Basically, if it is pleurisy, that means the restrictive disease is there. So yes, it can be done. Pleurisy is not a sorry, pleurisy, chest pleurisy. Okay, so in the case of pleurisy, we don't need to do the spirometry.
No, he's having pain. Actually, he's having pain, but he has come for spirometry. So can you do it? Like he's having pain in the chest because of pleurisy.
But why he has come for spirometry in pleurisy?
So yes,
See, if the child is having pain, then obviously the results are going to be suboptimal. So if you already have diagnosed that the child has pleurisy, as said by Sarika, that if the child already has a pleurisy, then there is no sense of doing a spirometry. But any child who has a painful condition of the chest, it is a relative contraindication.
If a child has got allergic rhinitis, can he or she blow in a spirometer?
Yes.
Yes. I think that is not difficult.
Anyway, you are using a nasal clip, so it doesn't matter. The child is not going through the nose. The child is going through the mouth.
Yes.
Okay. Then there is a question, very important question. If PFR takes care of larger airways, can it be used to monitor the response to treatment in pediatric asthma?
It cannot be, because it is a test which is not very reliable. The specificity of PSR is low, and it measures the larger airways. So most authorities do not use a PFR. The variability is too high. It is not very standardized. You do not have reference standards. So most authorities do not use a PFR for monitoring. The only role of PFR, which has been there used throughout the world and now getting slightly out of use, is for using it for an asthma action plan to understand the current symptoms. If the child has current symptoms and possibly the PFR has gone down, it indicates an early asthma attack and management of asthma. But in pediatric age group, this doesn't happen. The symptoms occur early, and the PFR doesn't help us to guide management. But for diagnosis and for follow-up of asthma, PFR never had a role except for looking at the variability.
Okay.
I
Sir,
will
I just
At
add.
this point, PFR, the recent studies as well as per GINA guideline also, and soon I have my paper also, that PFR monitoring in context of personal best PFR is useful to monitor exacerbation or the level of control at home, especially in this COVID time when this spirometry was not able to be done properly because of all the hygiene and infection control measures. So there are now the studies coming. The last 10-15 year studies all said that PFR is not a good. There is lot of variation, subjective variation. It is large airway. But if the child is well motivated to monitor personal best PFR, he had his level of control maintained. So though then this personal best PFR can be used to monitor further any deterioration in level of control of asthma.
Okay, okay. So that you require to know his personal best after he has fully controlled. Then you have a monitoring over about 2 to 3 weeks, get his personal best, and then probably you can use that value to predict an impending attack or variability of whatever. For that, you have to need to know his personal best. Uh, sir, if a child is having hyperelastic chest wall and they empty the entire FRC in a minute, in that case, should we use FEV 0.75 instead of FEV1?
Yes, so I think this FEV 0.75 or zero point 0.5 is used as one of the parameter in preschool spirometry because they empty their lungs very fast. But in older children, usually above 6 years, it is FEV1 which is used. So in smaller children, as I think Ankit was showing the difference, FEV 0.75 or 0.5. Only problem is the reference data are limited about these values, and therefore there is a problem. But that's a good concept because they would empty their lungs within 1 to 2 seconds. Yes, it is useful.
When a child is on budesonide therapy and he has not come for follow-up, what changes do you expect in spirometry?
Spirometry is obviously, if the child is clinically well, you look at the previous graphs and you expect that the spirometry values are getting back to normal. But you have clinical situations when there's a discordance between symptoms and spirometry values. So the symptoms improve, but the spirometry still shows obstruction, and this is documented throughout the world. And in such situations, the tapering of medicines, you have to understand that you might need to continue with the same drug. Sometimes, if that is not improving over time, you might have to actually increase or hike up the dose of inhaled corticosteroids, wait for the lung functions to get back to normal, and then reduce it.
Sometimes in a graph we are getting only abnormal parameter is FEP for expected flow turned out 70%. So then how do you go ahead? All are normal excepting that MMEF is abnormal. So what do you do?
So abnormal means if
Yes,
your small airway disease, I think it is one of the criteria for diagnosing a small airway obstruction or distal airway disease. If it is less than 65% and if there is a good bronchodilator response, it may indicate the initial obstructive airway disease. So maybe you can give a trial, you can follow these children, that is out. So it may tell you that it is, as we discussed in the graph, in the initial part, only the small airways are affected. Asthma is an inhomogeneous disease. So only the distal parts are affected, and as the disease progresses, you will get changes in other parts. So theoretically, yes, but again, I think Ankit had said that FEV1 25-75 is a variable parameter. It may not be reproducible, so you have to take the clinical context in mind.
What's your Ankit sir?
Rightly said. So see, if you look at small airway disease, then there are lots of ways to monitor it. And there are meta-analysis which have been published in Lancet, which talks about evaluation by FEF 25-75, by plethysmography, and by oscillometry as well. So if obviously if you do not have an oscillometry or if you do not have a plethysmography, you can still look at this. So it depends on the clinical context. It depends on the clinical context. So if you actually find that the child is improving, but the child still has small airway disease, then obviously you continue the same amount of inhaled corticosteroids and repeat a spirometry after 2-3 months and see, and compare the two graphs. And obviously the comparison will also tell you about the improvement in lung function. So I think it has to be in the clinical context because these values are in isolation. Sometimes they are not very specific.
Yes, so I think if we are very clear that FEF 25-70% is not a reliable parameter because there are no fixed guidelines, there are no fixed values. So it is very difficult to interpret that, and the spirometry itself is a very poor test to tell you about small airways because they have seen that after 9/11 attack at US, those patients who were normal on spirometry, on impulse oximetry, they showed a very clear small airway disease. So spirometry sometimes it cannot be a very good test to detect small airway abnormalities, and that can be detected well on impulse oximetry. So an isolated abnormality in FEF 20-75% may not tell that it is asthma. It may or may not tell. You have to see other parameters, you see clinically, repeat the test or do an impulse oscillometry to confirm it. Then what is the best spirometer? You have told that it is flow sensor, and then you have told a number of things regarding flow sensor. So what is the best spirometer to purchase?
I think you can contact us personally. I don't think we should say any name on this forum. I think basically ultrasonic technology you can use, and there are various companies who have a portable spirometer with ultrasonic technology. You can go for that.
So it depends on what system you want to use, whether you want a portable system, whether you want a desktop-based spirometer, whether you want a USB-based, whether you want a monitor with the spirometer, whether you need a thermal printer. So it depends on what you want, whether it is for an adult lab or a pediatric lab, or it is for both. You want to do it in the field or so. So it depends basically on that. Ultrasonic based or the pneumatic based spirometers are quite good and they are quite reliable.
Then there is one question: is that a child is on controller therapy and there is no bronchodilator reversibility, and the patient is symptomatic. How to interpret?
You need to look at rest of the things. The child is symptomatic because of rhinitis or sinusitis or GRD. So look at alternate diagnosis because if the child is if the child has asthma, now the lung functions are normal. It basically means that possibly the asthma is well controlled and you are possibly looking at comorbid conditions.
Yes. Then there is some confusion regarding the percentage of the normal. If you want FEC, they are telling that in the recent GINA guideline it is 90%. So I think we agree with that. 80% is for adults, and for children we take it as 90%. Any value, even FEC which is below 90%, it is considered as a normal. 80% is for adults. What is the opinion?
Basically, it is for the Z scores. So we all have to understand that the ATS and the ERS recommends the lower limit of normal of the Z score instead of using a percentage. Most guidelines do show a graph, and if you're using the current standards, so either use Indian values which are hardly available. You can use the GLI values which has the column of others. If you're using that and you're using the lower limits of normal, which should be provided by the software which you're using, then that is actually the best. Okay, these fixed values tend to under and overestimate the obstruction. But still, if you do not have lower limits of normal available to you, look at the shape of the graph, the scooping of the curve, and the response to bronchodilator. So I think sometimes the curves appear scooped, the FEV1s, the values might be a bit low. So supposedly the value of the FEV1 is like 85%, but the normal of the child is like 95%. Okay, and once you do the bronchodilator response, it shows a significant change in the shape of the graph, and the FEV1s improved by 14%. So technically, the FEV1s were not low because the cutoffs were 80%. But there was a clear slight scooping in the curve, which means there's an early obstruction, and there's a significant bronchodilator response. So this is something which is extremely common with pediatric spirometries. We see this day in and day out.
So about this confusion, about lot of confusion about the FEV1 FVC ratio. FEV1 FVC 80% is taken as standard. About the ratio, as Ankit said, ideal would be to look at the lower limit of normal. So there is a table which shows predicted, and then there is a table which shows lower limit of normal. So compare the best patient value with the lower limit of normal. If the patient's value is higher than lower limit of normal, then the ratio is normal. So to simplify, I said it 80%, but less than 10 years, you can remember 90%, that's fine. So, but in general, 80 to 90 is
I think
fine.
it is not just one value.
And
Which
one
is
value, it's a,
it is,
and
it is about
yeah.
the clinical, it is about the patient, it is about the shape of the graph, it is about the FEV1, it is about the ratios, and it is about the change in the shape of the graph and the values after the bronchodilator response. So it is not just about, just one value which we are worried.
Yes, absolutely. So I think you have answered it very nicely. But to keep close the controversy for children, if you're going to see only the ratio, it is 90% because GINA new guidelines they have told children it is 90%. So any value which is 90% or
Less
low
than 10
for
years.
the ratio, it is.
So less than 10 years, or you can look at the lower limit of normal.
Yes. And the last question is that how do you compare iOS with spirometry, which is more sensitive and specific?
So I think we have been using iOS for the past 10 years or so. We started doing iOS in 2012 when I happened to be in Kalavati Saran Children's Hospital. And thereafter now, since 2015, we had an equipment in BLK Hospital and then in the clinic as well. So we have been doing it routinely. See, what we need to know is that, iOS is meant for a few centers which are practicing exclusively respiratory medicine, and spirometry should be there for most patients. The gold standard still remains as spirometry. Oscillometry has been good in the sense that you can test the children before around 2-3 years of age. They say 2 years, but I don't think that it is easy to do at 2 years because they're a bit reluctant and cranky. So around 3 years, we start doing iOS. So it is quite useful in children between 3 and 6 years of age. In children more than 6 years of age, it is quite useful, especially when they are symptomatic, but their spirometries are normal. And the iOS shows obstruction. So that means they have a small airway phenotype to the disease. But remember that there are huge number of patients, which I can show you, who have obstruction on spirometries and the iOS tend to be absolutely normal. Right? So iOS alone without spirometry is not a very good tool. iOS with spirometry has a value which is add-on. So now we did a thesis, our DNB thesis also, when we tried to compare oscillometry and spirometries, and we realized that you can have falsely normal iOS values in many patients. So don't think that iOS is a technology which can change the world. So iOS in isolation in older children is not something which is a very good tool. So still the world believes that spirometry is something which is the gold standard. If you need to get an iOS done, you can always send to a few centers who are doing an iOS if you actually need to. So that is what I have understood in the last 10 years. So in all patients now, if we do a spirometry, because I have the same equipment which does both, I do an iOS and then I do a spirometry.
Thank you, sir. Thank you very much for a very clear view regarding iOS and spirometry. So I think we come to the end of this open house, and now we will not take a break because we are late by about half an hour. So we straight away go with the session of Dr. Pawan Kalyan, where we will discuss cases where we actually interpret the spirometry report in these children. So I'll request Dr. Pawan to start a session, please.
Dr. Pawan?
Yes, I'm calling him. He's starting. Yes, sir. Please.
Sir, can sir share the slides? Or should I? 1 second, sir. I'll share. No issue. So every speaker has told about certain things and we have to understand. The only thing I just wanted to emphasize is most of the people who come do spirometry just ask the patient whether the nose clip is put on or 50 to 60% of the patients would not keep a nose clip on and they would be done and we'd have a spirometry report. So that is one thing which I wanted to emphasize. Whenever you do a spirometry, please try to keep this nose clip on. The second most important is, as we said, who is the culprit? So the first step is it the child's report is acceptable and reproducible as it would be mentioned in the comment, which the acceptability and reproducibility criteria has been well told by Dr. Bafna sir. No, it's roughly, can you tell this child has an asthma or obstruction like illness? Yes, when you see a scooping, which would have a rough inspection, then you think of an obstructive airway disease, or when your graph is small, as you see, it is a restrictive lung disease. So how do you look at the indices? As everybody mentioned, look at the FE1, FEC. This is what you need to remember. FE1 by FEC, followed by FEC and FE1, and FEF 2575, still we don't have a normative data, so we are not giving much importance and it is variable. So that is the reason, even though it been showing that it has been reduced, we don't take with much this thing. Only thing is FE1 by FEC, FEC and FE1. Now again, the same slide what Dr. Bafna sir has mentioned, obstructive disease is always FE1 by FEC is low, FEC is normal, FE1 is low. In a restrictive lung disease, it is either normal or increased, your FE1 by FEC, FEC is reduced and FE1 is low. In a mixed, all three are low. Now let us see some of the case scenarios which we would be seeing. In a case 1, Lakshmi is a 15-year-old girl who is a known asthmatic who has been diagnosed, and she's having intermittently the symptoms like cough and wheeze, and she has an significant exercise-induced bronchospasm. That is, when the child cries or whenever she goes for the exercise, she becomes dyspneic. So she has an exercise-induced bronchospasm and she's been on regular preventive treatment. So she was advised to do a PFT. Now if you see the PFT, roughly you could see some amount of scooping here. Where you can see a scooping here, which suggests there is an obstruction before you go and look into the yes. In the slides shown by Dr. Bafna sir, they have shown you the 2 trials and the best trial. Here, it is all depends upon the computer, where whenever you wanted to take, it would ask what way the format you want it to be. So I have taken a format where your bronchodilator is the FE1 by FEC 63, which is low, which is less than 80%. Then the next would be FEC, which is 105, which seems to be normal. FE1 is low. So in the first graph, if you have learned that FE1 by FEC is low, FEC is normal, but FE1 is low, could be a sort of obstruction. Now, you have done a bronchodilator and you asked for a change. So there is a 12% change. So which means there is a bronchodilator response. Here you should understand that being a known asthmatic, you should know what preventive therapy is on. If she is having a long-acting beta-2 agonist, your salmeterol or formoterol, you need to stop it 12 hours prior to your test, or a short-acting beta-2 is a 4 hours, which have been told in the previous slides. So now the interpretation, once you see the comment, the spirometry is reproducible and acceptable. As I showed you, there is a low ratio with normal FEC. FE1 is low with good reversibility. As I showed, there is a 12% increase. I would have talked about the evidence of small airway disease because there is no normative data, and the flow value you are seeing able to see what you call scooping, which suggests an obstructive pattern. Now they have written as obstructive airway disease moderate. If you have listened in the previous lecture where Dr. Bafna sir has shown the level of obstruction less than 70 mild, then you have a moderate of 60 to 50, and less than 39 is severe. So based on it, it has become a moderate obstructive airway disease. So the next case is a 6-year-old boy who is also known as asthmatic. So basically, the difference is in the Western world, they are done by the respiratory therapist. So the therapist would be sitting with them for 15 to 20 minutes for doing a spirometry. So you need to have a team when you do such PFTs, because it's very difficult to, the only doctor will go and do, but you need to see how they are performing. So the Ram is a 6-year-old who is a known asthmatic, who is on low dose intra ICS budesonide and having intermittent symptoms of cough and wheeze, who is responding well to the reliever medications, that is your Livolin or levosalbutamol. Now he was asked to do a spirometry, and you can see the FE1 by FEC ratio is less than 80%, which is 74, that is there is an obstruction. But you can see roughly there is a graph here, but you are seeing so much of variation here. So during the spirometry, the child was coughing. So whether the spirometry to be taken or not would be told by the therapist who had been done, where they say this spirometry is acceptable and reproducible. Without that, you cannot interpret the whole story. So this, when I talk about, this has been taken, we have seen the report that this is acceptable and reproducible, because in the first slide, when you have a cough, it could not be taken up in the first 1 second. The child is not, so you need to look into that one also. So the FE1 by FEC is 74, that is less than 80%. FEC is 93, which is normal. FE1 is low, less than 80. And you have a good bronchodilator responsibility reversibility, that is 29%. Now the spirometry is reproducible and acceptable, that's what they have written. So you have a low ratio with normal FEC, FE1 is low with significant reversibility after bronchodilator, that is 29%, and flow volume is consistent with mild obstruction because it is only less than 70%, and this is reversible small way air obstruction. In spite of your treatment, if the child is been having, then you need to step up the treatment, or are there any aggravating factors which has caused this, we need to look into, because it's only a small. Now case number 3, this is a WB child who is a 14-year-old boy who has a background of Duchenne's muscular dystrophy, which one of the and scoliosis, and this child has infrequent episodic asthma and osteoporosis. So when you see such cells, because of scoliosis and everything, you need to do a Cobb angle, because whenever they do a corrective surgery, before a corrective surgery at the Australia, we used to do for all scoliosis patients, we used to do a spirometry, because whether this would be causing any further derangement, worsening of the things. And when you have a DMT, or sometimes who have been bedridden, we take, because you need to take the height. So when you take when the child cannot stand, we see the measuring arm length, and then we calculate based on it. Now here you can see the graph that is very low. So by the rough criteria, it is not showing any scooping, but it is slow with which is equivalent to. So this suggests that there is a restrictive component here. Now see the FE1 by FEC. It looks very, very normal. FEC is low, FE1 is low, and there is no bronchodilator, it is negativity. So sometimes you may also find such things, or you may also develop a spirometry induced bronchospasm. So whenever you do each time, your bronchospasm increases, which I haven't put here a case. Sometimes we do see such cases also. So the spirometry is reproducible and acceptable. As I said, there is an increased ratio with low FEC, low FE1 and FE25. There is no response with bronchodilator, and flow volume is consistent with your restrictive pattern. And this again says that you know the child is a DMD case, scoliosis, you definitely see a restrictive lung pattern. Now this is a PK who is a 16-year-old female who is a known case of cystic fibrosis and a pancreatic insufficient child who is on regular tune-up. That means whenever having acute exacerbations, the child would be admitted and be given IV antibiotics for 14 days. So she's been on regular therapy, and is also non-chronic suppurative lung disease, and the CT scan was showing bronchiectasis. So
Pawan, sorry to interrupt. Somebody wants the previous slide. Can you show them? Sorry to interrupt.
No problem, sir. Which one, sir? This one? This one, sir? Or the previous one?
They wanted the previous slide, previous to the one which you were talking.
Yes, that restrictive one. That
Restrictive interpretation.
explain this once again.
Okay. So here on the roughly looking at the graph only, you are seeing a low flow volume graph, which this is the original graph which is supposed to be, and this is what it has been there. It says that yes, you can roughly say this is restrictive lung disease. So the FE1 by FEC, which is normal or increased, that is more than 90, it is 92%. FEC, after that FE1 by FEC, we look into FEC, which is showing low, and FE1 is low. So when you see the increased ratio with low FEC and low FE1, I am not talking about FEF 2575 because there is no normative data as such. And when we did a bronchodilator, you could also see that there is no change. It's only negativity. So it is not, if it is more than 12%, you take it. So, and the flow volume loop is consistent with restrictive pattern. So this suggests of restrictive lung disease. Anything more, sir? Because the most probable question what they wanted to ask is, because of minus 14%, everybody are worried that what is this minus 14%? You would not, every patient would not have a bronchodilator response, and you can see a spirometry induced bronchospasm, which we are not talking about here.
So one thing is that a low FEV1 in this child, how do you say? Because although you have documented there is no bronchodilator reversibility, but how do you account for a low FEV1 in this child? Well, ideally it should be.
So in restrictive lung disease, Dr. Rawat, your FVC is low, so proportionate decrease in FEV1 is also expected. Because all the volumes are low, whatever volume is coming out in first second, maybe more than 80%. But because say the lung capacity volume has gone down, whatever air is coming in first second also will be low. So there is a proportionate decrease. That's why the ratio is normal. But FVC is much more affected than FEV1. Therefore, the ratio maybe initially FEV1 may not be low, but later on, because all the volumes are low, even FEV1 will be low. So
no, sir. The absolute volume of FEV1 can be low, but the percentage will not be low. If percentage is low, it indicates there is obstruction, because I can understand that if it is an restrictive lung disease, you will have also low volume of FEV1, but the percentage, it will be normal. If it is low, it indicates obstruction.
No, sir. Percentage is percentage predicted. So for that age, for that sex, and for that ethnicity, suppose FEV1 expected is 2 liter, and if the patient's FEV1 is 1.5, then it will be 75% or whatever. So the percentage will also go down. So simple thing to understand, FVC is low because there is a restriction. FEV1 is not low because the flow is a problem, but because all the volumes have gone down, volume of air coming in first second will also be low. And therefore, the percentage of volume coming out, that is 80%, will be normal. But the ratio will be normal. But FEV1 percentage of the predicted will be low. It may be low, it may be normal.
So this child had been already on drugs. So if it is on drugs, you may not get reversibility on bronchodilator test. So you can just tell that it could be a mixed disorder, not a plain restrictive. It could be a mixed, and since child is on drugs, that's why you couldn't document reversibility.
Sir, point number one. Okay, sir. Vapna, sir, please go ahead.
So, sir, for mixed disorder, the ratio will be low. Here, I think the FVC is low because it's a restriction, and FEV1 also goes down in restrictive disorder. As we said in the table, it may be normal or it may be low. It may be normal because the flow is normal, but it may be low because your total lung volume has gone down. Therefore, the volume coming in first second will be, so proportionate decrease in FEV1. It is a proportionate decrease. Therefore, the ratio will remain normal. But if you compare that FEV1 with the predicted value for that age and sex, then it will be low. So that's the concept.
Okay.
Basically, that is the reason I have brought the concept, sir. If you see there is a scoliosis, you can see, so the volume which is coming out is low. That is the reason what you are getting is low, sir.
Okay, fine.
So this is a 16-year-old female who is a cystic fibrosis, pancreatic insufficient, who is on regular tune-up. a case of a chronic suppurative lung disease, as you see, and the bronchiectasis has been seen on CT scan. And this is what you have seen, where you are able to see there is a low volume as well as scooping. So here the FE1 by FEC is 54, FEC is low, FE1 is also low. Where all the three parameters are low, then this fits into mixed variety. So there, this is a mixed pattern, and to say which is more, is it the restrictive pattern is more or obstructive pattern is more, would be told by your FE1, because that FE1 is very, very low, which shows obstructive component is much more than your restrictive component. So this is a spirometry which is again a reproducible and acceptable one, where you have a low ratio and a low FEC and FE1, but we couldn't do the bronchodilator response, and the flow volume is suggestive of mixed pattern of restrictive and obstructive disease, and in both of which is more predominant is the obstructive pattern is more predominant than the restrictive pattern.
So I think it's very important you have brought out that if you have got a both mixed pattern, you have to see both FEC and FEV1. If FEC is affected more, probably restricted is more. If FEV1 is affected more, probably it is obstructive. I think this is a very important thing which you have brought out.
And the response also, sir. If there is a good bronchodilator response, then obstruction is significant.
Correct. So these are real cases, but this will not occur at any, you may not be able to see such cases in our scenario. This is where I've worked in Australia, I've taken that slide. So this is a case of a 10-year-old boy who has initially presented with 8 weeks history of persistent vomiting of regurgitated, undigested food and saliva, and 3 to 4 months history of persistent cough, and there is a progressive vomiting and regurgitation, there is a history of decreased oral intake, and there is weight loss of 5 kgs. With this history, because a persistent cough, even though you have a gastrointestinal symptoms much more predominant, people would ask, why would you do a spirometry in such cases? But the patient has been referred for spirometry, even though there are such complaints, even though it is fitting into some GI manifestation. Why this child should have a persistent cough? That is what the referring pediatrician has referred, the general pediatrician has referred for a spirometry, and we did a spirometry in such case, and this is what you have seen a loop, where your FE1 by FEC again is low, FEC is normal, and FE1 is low. So you are seeing some amount of obstruction here. Even though there is no very much of the scooping pattern, you are able to see a small scooping. This is a pattern of obstructive airway disease. So here I would also like to mention, even though this is, if somebody looks and asks why FE 25, 25, 75, in every case if you see, because it is an effort dependent and it is not variable, you have a low. So when we interpret this, they said that, hope you are able to see the bronchodilator response. I would again show you that. Yeah, and they have done a bronchodilator and there is no change, there is no 12% increase. So this spirometry was reproducible, acceptable, and you have a reduced ratio of low and low FE1, and there is no significant response. You had an obstructive pattern with no reversibility, but what is the cause for having such obstructive pattern and no reversibility? Now again we'll go back to the history where you have regurgitation and everything, and persistent cough. Here the flow volume loops, if you see there is an intrathoracic obstruction which is consistent with probably a tracheal obstruction. It is probably the one of the differential between eclasia cardia, where because of the vomiting and regurgitation. Here in generally in India we won't come to this. This is because in Australia, because they had that, they have done it, and the restriction of mid flow volume loop is due to air trapping secondary to the compression of the airway rather than the disease per se, not because of the small airway disease. So this is what, because we wanted to show you the variable intrathoracic airway obstruction, people would say, but where would we see? So in a case of trichomalacia, when you ask the trichomalacic people, the child would have what you call a brassy cough, and when you give a nebulization, it would cause worsening. So in such cases, you could do. The problem is that the people has to be little, the trichomalacias would be seen in younger age group after preterm at what you call 4 to 5 years of age, where you would be seeing recurrently. By the time they come up, sometimes your trichomalacia, because the trachea grows, that you would not be able to see that amount of, until unless you have a secondary trichomalacia because of compression, which we have talked about. So this is the problem where That is the reason we could see the intrathoracic fixed airway obstruction, not sorry, intrathoracic variable obstruction. Now, this is a DN girl who had been 2 days of persistent symptoms of difficult breathing and history of noisy breathing since last 2 years. And that too, you have an inspiratory stridor and equal air entry on right and left lungs. When you see such cases, we don't generally do a spirometry. We generally look and do a bronchoscopy and see what exactly is happening when you see such patients. Noisy breathing and inspiratory stridor. When you take some of the history, they would say that the child has been intubated or ventilated for some of the reasons. That is the reason where you would see some amount of stenosis. But out of curiosity, the child, we have done a spirometry where you see FE1 by FEC is low, FEC is normal, and FE1 is low. So you see a marked reduction of ratio of normal with normal FEC, low FE1, and I'll show you this slide again. Here you are seeing a rounded one. This suggests of fixed airway obstruction, could be a subglottic stenosis. So when you go back in history, why people would ask, why would a pediatrician ask for a subglottic stenosis? Generally we don't, but sometimes for the sake of interest we would do, because the stridor is what, when you have a severe stridor you want to experiment such things. So in the case of small stridor, it's been intermittent and the child was able to breathe well, and suddenly the child developed of some viral infection, you would see. So the flow volume loop is riveting flattening of loop on both faces. Classic picture of fixed central airway obstruction, a probably case of subglottic stenosis. But your history would itself give that if there is a previous history of intubation and ventilation, this would be the case.
So I think you have given very important message that along with the interpretation of the figures, you have to look at the loop also, because if you don't look at the loop and if you only go for a low FE1 FEC ratio and low FE1, you will think that it is an obstructive disease. So it is very important to look at the shape of the loop, the curves, and then only interpret the entire report. I think this is a very important message which you have given.
Generally, we don't do a scoliosis corrective surgery. We are doing, sir, but the orthopedician do not refer for a spirometry here. But every Tuesday, where they would be taken for a scoliotic corrective surgery, that is the idiopathic scoliosis, where they would definitely do a scoliosis to see how much would be there, because if the FE1, if it's very low, whatever we have seen, 50%, during anesthesia, the problem with anesthesia, because we are not doing spirometry for any of the child, because the anesthetic complications would be seen in such cases. That is the reason they ask for a spirometry. So this is some take-home messages which I have learned, sir.
Thank you very much. So I think you have given excellent cases and you have given an excellent interpretation. So again, we want to repeat again the thing that whenever you are going to interpret a spirometry report, please go methodically, because you don't jump onto one particular parameter. Don't jump on one thing. Always go stepwise. See whether the graph is acceptable. See whether it is reproducible. See whether all the parameters have been entered properly or not, and then go see the ratio, see FEC, see FEV1, and then make a diagnosis what you are treating, whether it is an obstructive disease or restrictive or mixed or a central obstruction in case you have got an inspiratory also. So I think things are absolutely clear. Thank you very much. And now we go to the next talk on PFR, which will be taken by Karika.
Yes, sir. Yes. So the next topic is about the peak expiratory flow rate. A bit of it we have discussed in the question answer round, but for a formal talk, this is the talk. This is the presentation. So next slide, sir, please. So the learning objective for this class is that what is the working principle of peak expiratory flow rate monitoring, how to do this procedure, what is the utility, and of course the limitation of PFI monitoring. Next, sir, please. So peak expiratory flow rate. So it is the maximal flow rate that a person can achieve during a short maximal expiratory effort after a full inspiration. We will discuss the detailed procedure in the upcoming slide. So, although the different guidelines have recommended, and till now we are educated enough to know that the gold standard for diagnosis of asthma is the spirometry. But in the resource limited setting, either because of the cost factor or because of ability or because of a pandemic when this test is not being able to done, the PFR may provide an objective measure flow of airflow limitation when spirometry is not available for a different reason. But at the same time, we should always know that it has many limitations, as Dr. Ankit has emphasized, and it is mainly useful for asthma monitoring. So for the diagnosis, role of PFR is not very much. Next, sir, please. Because it gives a crude estimation of lung function, and basically because it is measuring the flow from the larger airway, and we all know that the asthma is a disease of a smaller airway, so the PFR is not reflecting the values of the smaller airway. It is less sensitive, less reliable, and its value decline only when the obstruction is severe. It is possible that just for some degree of obstruction, PFR value may not decline that much. Only with severe obstruction it is there. So these are the some of the limitation that has been observed, and it definitely it depends upon the voluntary effort and muscle strength of the patient, especially of the abdominal muscle to do this maneuver. So it has a lot of subjectivity too. So the procedure, the way that it is done, it is that first, as for the spirometry or any other procedure, we have to explain the steps of the procedure to the child's and parents. Next, sir, please. Then we have to uh, make the parent and the child familiar with the spirometer. Fix the mouthpiece to the peak flow meter. So if it is ideally, the peak flow meter should be used the personal one only, because for this to prevent any respiratory contamination infection. So in office setting, if you are using the same peak flow meter, use the different mouthpiece for different patient. And so fix the mouthpiece to the peak flow meter and move the indicator to 0 at the base level. We will show next slide. And then the child is asked to take a deep breath. So take a deep breath, then place the peak flow meter in the mouth with tight seal around it, and then blow. The child is asked to blow with maximum effort he can do. And next, sir, please. So the indicator which was at the 0 at the base level. So with this effort, that indicator will move up to a point. So that point is marked as the peak, the PFR in liter per minute. So the child is asked after deep inspiration to hold the peak flow meter in the mouth with tight seal. Then he's asked to blow as hard and fast. And the position of the indicator is then checked against the number written on the peak flow meter. That is, for example, he had blown up to 150 or 200 or whatever. And the step is repeated 2 more times. And the highest of the 3 values recorded is maintained in the diary, morning and the evening value. Next, sir, please. So in this video, it is shown that how we measure the peak expiratory flow rate. So first indicator was 0, inspiration, followed by putting in the mouth and blowing hard. And then we will check the indicator that up to which value it has come. So this procedure will be repeated 3 times, and the highest of the value achieved will be recorded in the PFR diary. So the normal value as per spirometry parameters, PFR, also depends upon age, gender, height, and ethnicity. And the gender and height-based charts are available. And more than 80% of the reference value is considered normal. But the best one is the personal best PFR, like when the patient is having controlled asthma, he's free of any exhibition, then whatever the best value he's having, that individual index patient is having, and all the calibration as per that value is taken as the personal best. YouTube recording link of today's session. Dr. Sanjeev sir will tell about that. Next, so this is the PFR chart. So it is that which is taken from the AIMS pediatric pulmonary protocol. So for increase in height of 10 centimeter, there is increase in PFR of 50 liter per minute. So for the height of 100, it is 100, 110 pay. It is 150, and then for every 10 centimeter increases height, the normal PFR expected is 50 for every 10 centimeter increase in height. But as we discussed, that personal best PFR should be taken as the reference. Next, so please. So personal PFR, it is the highest measurement achieved when patient is free from signs and symptoms, and it is obtained by recording PFR twice a day during a period of 2 to 4 weeks when asthma is controlled. So in this 2 to 3 week of asthma being controlled, the highest value of PFR that is achieved is labeled as the personal best for that child. And if PFR decreases by 20% of the personal best, then it is likely to be an onset of exacerbation. So as we discussed that usually PFR value decreases only in the severe obstruction, but if we tally with the personal best PFR, any value less than 20% of the personal best is onset of exacerbation. Can PFR tells we can stop nebulization and patient can be started on inhaler? Your question is not clear to me. Please frame it again. So clinical utility of PFR. So it is assessed to response to treatment. So if PFR diary is maintained and the PFR value is showing 20% or more improvement on treatment, then it is a response to the treatment. And it is also used to monitor the level of control. So change by change in variability, change from personal best value. Next, sir. And if there is a drop of more than 20% of the personal best PFR, so it identify the impending exacerbation and the appropriate measure can be taken even at the home. Next, sir. And in the diagnosis, it has limited role. Although it has been mentioned that if the day-to-day variability is more than 13% of the PR, it is suggestive of asthma. But the lesson being learned that should be learned from this class is that the PFI should not be used for the diagnosis purpose. For monitoring, it has some role, but not for the diagnosis purpose. Yes. So as told that excessive variability of the PFR over 30% when observed over 2 weeks, it is seen in asthma, but it should not be the diagnostic. And how we calculate this variability? So variability is calculated as days highest. So first we record morning and evening PFR for 1 to 2 weeks, and then the days highest minus day lowest, and divided by the sum of them divided by 2 is and averaged over the 1 to 2 week is taken as the average value. And if it is more than 30% variability, then it is suggestive of asthma diagnosis. Next, sir, please. So for home monitoring PFR, so this PFR did well during the time of the COVID when there was lockdown, when the PFT is not being done, when the parents and child were not able to come to the doctor. So if the PFR value is 80 to 100% of the personal best. So in that condition, the child has to just follow regular medication plan and go ahead with normal activity. If the PFR is 50 to 80% of the personal best value, so this is a caution. So it is like that the asthma may be worsening. So the asthma medication instruction should be checked, compliance should be checked to get back to the green zone. And if it is less than 50% of the best reading, so it is an alert that the child is having exhaustion. So in that condition, medical advice and attention to the major intervention should be done immediately. So by this value, that is 80 to 100% green, everything is good. 50 to 80%, be cautious. Less than 50% of the personal wealth, that is exhibition is there, managed accordingly. So this these are the three colors shown for which the patient and the parents are trained to monitor and intervene accordingly. Next, please. So to summarize, so it is a good monitoring tool for assessing the treatment response and to monitor asthma control. And its role is asthma diagnosis is limited. And home monitoring may provide early cue to the acute exacerbation. Thank you. So there.
Thank you, Dr. Sarika. I think I'll need one clarification from the group, all the faculties. If you see the new GINA 2022 guidelines, where they have clearly mentioned that even WHO in resource limited settings, they have confirmed that PFR can
Yes,
be
sir.
used to diagnose asthma. And if you document a 20% reversibility, like 20% improvement in PFR after salbutamol, you can label this child as asthma. And even WHO also has confirmed that they are using this in their kit, and they are recommending the use of pipiclometer for screening for people for asthma. So I think we need to make this issue very clear in front of the delegate, that what is the current status of PFR in asthma diagnosis and monitoring according to GINA 2022 guidelines. Yes, so Sarika, would you like to respond?
Yes, sir. So in this post-COVID era, the point of view of towards the PFR has changed. Now it has been recommended by different guidelines that the PFR is a good one for short-term and long-term monitoring in resource-limited setting, definitely for monitoring, and in some condition for diagnosis also.
Bhavna sir,
But it should not be taken as the first test for the diagnosis, PFR.
Bhavna sir, unmute, please, unmute.
So peak flowmetry actually has, it has, I think, completed a circle. It came like a few decades back. Peak flowmetry came as a bang, that is a very simple tool. You can diagnose asthma. Then it went into disrepute, and now again, I think the recent guidelines are saying yes, it has some role, though not as gold standard as spirometry. There is some role, particularly in resource limited countries, particularly when spirometry is not available, particularly in office pediatrics, where you can use this tool. Now, as we know, asthma, when you want to diagnose an obstructive or a disease like asthma, you need to document two things. We said asthma is a reversible disease which is non-homogeneous, which is variable, and the obstruction is reversible. So that variability and reversibility is the place where the PFR comes into play. So if you can document a variability, that your PFR morning evening PFR reading is there for 2 weeks, and there is a reversibility of 13 variability of 13%, then you know that there is definite variability. Same thing can be done for spirometry also. You can document a variability and it can be a positive response. Second thing is reversibility, as we said in spirometry also. Similarly, in a office practice, suppose you give MDR to a child and your PFR has increased by 20%. So it's not 12%, it's 20%. Then there is a clue that it is probably a reversible obstruction. That's how I would interpret. Yes, the guidelines, recent guidelines have said that there is a place. So I think you have to go from it. It has to be read in a proper context. Spirometry is gold standard. If it is not available, then there is something else which is there and you can use it. So it's not that you can replace spirometry by peak flowmetry, but it is one of the tool which can assess your response. Definitely for monitoring, it is a good tool because you can't keep on doing spirometry. And for patient education and for patient to keep something at home, definitely that's how I think in a holistic way I would look at peak flowmetry.
So I think the final statement would go in this way, that spirometry is definitely the gold standard. If spirometry is not available at your town, you can use PFR for documenting reversibility by giving salbutamol and document 20% improvement. You are justified in labeling that child as asthma. But with the first available opportunity, please send him to a place where spirometry is available and get a full spirometry done. It is a good tool for monitoring. You find out his personal best PFR, and that can use you can use that particular value to predict an impending attack, or you can predict, you can also see for variability where it will indicate that your dose of bronchodilator, your dose of ICS is not enough and probably you need to step up. So it is a good test to monitor a child who is not responding the way you want. And in resource limited condition, it can be used to diagnose asthma. But again, with the first available opportunity, please send for a full spirometry. I think this is the official line which probably we will be.
Yeah, and one more thing to add is you cannot rule out, like you have a 20-25% response. Yes, it's a clue. But if there is no response and there is child clinical context is showing that this child has wheezing and asthma, you cannot rule out that the peak flow was normal, so I have ruled out asthma. So that limitation have to be taken into account because it's a predominantly a large, it is telling you about the larger airways, smaller airways it will not. So as you said, even spirometry sometimes can meet subtle changes in small airway disease. So it's like that. So limitations have to be kept in mind.
Thank you. So now we come to the last session of this particular module. It will be on Feno, and Feno again, there are a lot of data, a lot of references regarding the use of Feno to diagnose asthma, to predict the use of ICS, to predict control. So we'll hear with Dr. Ankit what is the exact status of Feno in diagnosis and management of asthma.
Are the slides visible, sir?
Yes.
Yes, but start your.
Yeah.
They are visible. Yes.
Yes.
Right. So we'll go on to exhaled nitric oxide, or also called as Feno, which is fractional exhaled nitric oxide. And we'll try and focus on the current role in the management of childhood asthma. So why do we need a new test? What are the advantages of doing a Feno? What is the practical value and what is the limitation that we face? Right. So why do you need a new test? It is because it tells you the degree of underlying airway inflammation. So we always talk about inflammation in asthma. So we have a tool which can, tell you about the inflammatory component, not about the obstruction component as such. And it is possibly thought that it adds a new dimension to the traditional clinical tools of history, examination, and lung function. Now, whenever you are investigating inflammation in children with asthma, you can start from things like the volatile organic acids, the exhaled breath concentrates, FeNO, sputum eosinophils, which are thought to be relatively, because it requires the sputum examination and an inhaled sputum. And if you want a best result, then you resort to bronchoscopies and endobronchial biopsies. Now, out of these tests, Feno has been the most popular because of the availability, because of the ease of doing the test, and because it is non-invasive and it can be done in younger children. The underlying fact remains that patients with asthma have a high Feno level in their exhaled breath, and that decreases in response to treatment with corticosteroids. And hence it provides information about the current airway inflammation which is going on. Well, how is nitric oxide produced? Well, the normal epithelial cells produced minimal nitric oxide, but during airway inflammation, the activated epithelial cells increased the production of NO, and that is what is measured. So as I said, the advantages are the non-invasive nature. You can repeat it. It can be performed in younger children as young as 4 years of age. And even in patients who have severe airflow obstruction, sometimes who are not able to perform it, a lung function, they can perform a Feno. Well, the key question, not just for a Feno, but for any test, is that does it, add on to the management of children with asthma over and above your clinical diagnosis? So, clinically asthma, then what does Feno add? And similarly, we always ask the same question when you're talking about lung function, that, clinically it is asthma, then how does it help you? Well, it depends on whether it can, tell you the diagnosis. So I'm not clinically sure whether it is an asthma. So can Feno tell you it is an asthma, or can Feno rule out it is an asthma? So that's one. Does it help you in defining control, which is the domain of current impairment? And does it tell you the risk of exacerbations, right? So and hence it helps me guiding treatment. And obviously it tells you about the inflammation. So can it help you to adjust the medicine? So the child comes and follow up, and you get a Feno done. You realize that the Feno has significantly reduced. And it gives you, more confidence that this child is doing well, and I can reduce the amount of inhaled corticosteroids. So does it actually turn out into a clinical benefit? So Feno, different methods are available. The chemiluminescence is taken as the gold standard, but the equipment is quite expensive, and most of the labs do not do that. What they do is the electrochemical method, which is usually available at most places. The most important problem with the exhaled nitric oxide actually is shown in this graph, that you have this curve which is there, but the problem is that there's an overlap zone. So there's an overlap zone between the normative value and between the stable asthma. So if the values actually lie in this zone, in the gray zone, then it's quite difficult to make a diagnosis. So that's the basic problem which most people would face. People have tried and defined what should be the cutoffs which should be taken, because finally you need some cutoffs to be there for everyone to understand. So this is a general rule which people would follow. In adults, they would take low as less than 25 to 50 as intermediate, and high as more than 50. In children, it is taken as 20 to 35, and more than 35. If it is low, it is considered that Th2 inflammation is unlikely, or it is well controlled. And in the high, it means that the Th2 driven inflammation is there. And what it turns out to be is that if the values are high, then the child is possibly going to respond to corticosteroids, and it supports the diagnosis of asthma. In the low, it means that either the child is well controlled clinically, or if the child is not on corticosteroids, the child is possibly unlikely to respond, and you need to consider alternate differential diagnosis of chronic cough. It can be a vocal cord dysfunction, it can be a non-allergic asthma, or it is a GERD. So again, the interpretation of Feno falls into the clinical domain. Now, there is data which talks about, can you actually make a diagnosis of asthma on the Feno? So the problem is that the sensitivity and the specificity range is too wide. The positive and the negative predictive value, as you can see, varies from around 50% to around 95%. And it is said that approximately one in 5 people with a positive Feno will not have asthma. And conversely, 1 in 5 with a negative Feno still can have asthma. So Feno has not been found to be a very good test, a very reliable test for, ruling in or ruling out asthma in children. Then people have seen that whether it can help you to, look at exacerbations, and whether it can help you to titrate your medicines. Well, it has been seen universally that if you have a Feno group where you're doing Fenos every now and then and trying and adjusting your treatment, then this group definitely has fewer exacerbations, right? But the secondary outcomes like quality of life, symptoms, FEV1s don't change. But in the Feno group, they also get significantly more amount of inhaled corticosteroids, and that explains a better control. This was a meta-analysis which was published, which talks about Feno versus conventional management. That exacerbations were significantly low. The Feno, again, as I said, the Feno group had more amount of corticosteroids, but the lung function symptom scores were not really different. So in conclusion, what people understand is that yes, it might reduce exacerbations, but no change in day-to-day symptoms, asthma control, lung functions, which are seen. It can be helpful to guide asthma therapy in a subset of children, but not for all patients. And we further needs to, look at a randomized controlled trial that where Feno could be best used depending on the severity of asthma, in what setting, in primary care. What is the role of Feno in a less affluent setting like ours, where lung function is hardly available, and what should be the best cutoffs for Feno? So at the end, it is an add-on test for assessing airway inflammation. The utility is limited for asthma diagnosis because the false positives and the false negatives are high. It can predict steroid responsiveness in response to therapy. It can be used as a monitoring tool, can be useful for tailoring therapy, but not in all patients. And I think the current role remains in the endophenotyping of children with severe asthma. Although we do understand that phenotyping is not so simple, sometimes one tool can fail, and most authorities believe that we need to have multiple tools to assess whether it is an eosinophilic asthma or neutrophilic or paucicellular. Right, so that brings us to the end of the module, and to summarize, spirometry is an office procedure which can be done in young children with good communication skills. It should be done in all patients who have a suspected asthma. The most important the parameters are the FEV1, the FEV1 by FVC ratios, and the FVCs. Reversibility testing is a must during spirometries. PFR is a good monitoring tool for assessing treatment response and asthma control. However, the utility of PFR in asthma diagnosis is limited. Feno is an add-on tool and can be used for monitoring treatment response in a selected population of children, especially who are on the fag end of being severe asthmas. So these are the references, and we thank you, and I'll hand over to Dr. Bafna and Dr. Rawat.
Thank you, sir, for a very good detailed talk on Feno, because it was very well needed. The only thing, as a general preparation question would be there, that specifically in which cases of asthma in children I would like to do if because this question would often be there in their mind.
See, I would put it in a way that Feno should not be used in practice. We are very clear about it. On one hand, we are fighting that spirometry is not available. People do not have access to spirometry. They cannot interpret a spirometry, and using the Feno will create more of nuisance than of good to patients. So Feno should be reserved for centers who are running a pediatric pulmonology service for the state, where they have severe asthma patients, where they are monitoring these few patients, and in those circumstances they need endophenotyping, and in follow-up of these children, Feno can be useful. But doing Feno without doing lung functions doesn't make any sense to me.
Absolutely clear. So I think this is a condition. This is a test which should be used by pediatric pulmonologists. So for you all general pediatricians, I think we should restrict yourself to spirometry and PFR. But you should know this Feno is a test which is available, so that when you get a report from your pediatric pulmonology colleague, probably you should be able to interpret that what do you mean by high ppb or low ppb, whatever. So you should be able to know it. So I don't think there are any more questions. So I think we can conclude by some concluding statements. We have got some our EB members are there on board, and I'll request Dr. Subhashish Roy, if he's there, and Dr. Modi to please unmute and give their feedback regarding the module, what what did they think and what additional things could be done. Dr. Roy, Dr. Modi, are you there? Only they are not there. Dr. Suleiman is there. I'll request him to give his feedback regarding how the module went and what more thing which we can do and how the delegate can use this information to their best use.
Wonderful congratulations to Dr. Ankit, Bafna, Sarika, Pawan, everyone for being contributions, and not just that. I was seeing in the chat box the way the interactions happened. I could hear some of the versions while I was doing the rounds. My apologies for that. Some of them I could hear, and some there was some interruptions for me. But the flow was fantastic, and absolutely the doubt clearing, everything, and the way the attendance for the program and the interactions. Somebody was asking, please visit the YouTube. This module and many modules and the past lectures that you have missed are all available in the chapter that you can see. And I don't think I'm being a teacher by myself. I feel short of my words when I have to congratulate the team for that wonderful science. I don't know how much of efforts it is required to prepare every slide. We know by ourselves, because even one slide would take nearly 30 minutes as you intend to what you want to speak. So therefore, my dear friends, this is Bhagavad Gita for the chapter. In each sloka you can interpret in your own way, and by many faculties. It is always nice to see the explanations given by the experts. They are all the faculties and many more faculties in the past and in future. They are jewels of the chapter, and there's nothing like chapter. It's a virtual imagination of us. It is because of the resource persons that we exist as a chapter. So my dear friends, congratulations. And any small corrections, I will go through this thing personally at my time, and again I'd give the inputs to Dr. Bafna and Dr. Ankit and everyone. But wherever little I feel that one or two small little very minute corrections, if at all there, then I will individually mail to you. We can freeze at the end of the day. And I feel that this should be periodically repeated, not just inaugurated and left. Rava sir, we will have a mechanism by which our chapter will periodically repeat them, although they can watch on their YouTube. Nobody watches completely 2 hours or 3 hours presentations. YouTube watchers will watch only for 15 or 20 minutes of messages. Sometimes it may not be possible for them. So therefore, we would wish that everybody would get the benefits of it by frequent reinforcements. This is my humble request. And those of you are in the audience who are not the members of the chapter, at least I should get 10 members now from every module that we invest. So please, I'm talking like a financier, but this is what encourages to us the commitment from you, because of which many of us are working. And wonderful to see Dr. Rawat live and in action throughout the sessions, interacting along with the faculties. And thank you very much from my end. And I don't know if I have missed out on things. I'm extremely sorry in my comments, but I'm humbled that I'm in the forefront of a very excellent team. In a performing team, if you want to be the captain, it is your Purva Janmaka Punya, because of which you are the captain of a cricket team which is winning the cups. And I don't think I can tell you more than this. I've been a good batsman, good all-rounder and all that. But now I'm the captain, and it's my pleasure that everybody is performing. And you can understand, in the cricket team, captain lifts the medal, but it's the man of the match, and the persons who have performed are many. So with the humbleness, whatever comments I'm making is our comments, not my comments. So this is the feeling of even Dr. Ankit, Bafna, Sarika, and Subhashish, Modi, and everyone. So every one of us feel about the chapter, and we are passionate about the science. So with these words, I'll conclude. I'll hand it over to Dr. Rawat.
Thank you, sir, for your words, sir, for the kind words. Thank you, sir. Any concluding remarks from your side? Ankit, sir, any concluding remarks?
So I think the most important thing which I would just like to say is that spirometry is not like a blood test. There's a huge difference between doing a blood test or an X-ray or because it is dependent on the child and it is also dependent on the technician. And there is a learning curve for everyone when they start doing spirometries. And I think people who want to start doing asthma practice, they have to learn to do spirometries themselves. Unless until that is done, it becomes quite difficult to understand what goes on at the back end. So the quality control in spirometries is extremely poor in India. Mostly it is done by company people, which should not be advocated ever. The adult technicians will mostly refuse kids.
Ankit, in quick response to your inputs, our chapter is, at least if not in our tenure in the continuity, we are going to come out with a module and a training program for the second line, that is respiratory therapists and respiratory technicians. We are going to have modules for them. I think I would even request you to volunteer. We have to prepare the second line. It could be even counselors in asthma, how to take inhalation therapy. See, consultant is very busy, but he can tell, go and meet Mr. Sudeep. He will explain to everything and come back to me. Yes. Somebody, if you instruct him, he should be able to do the spirometry for us.
Absolutely.
We are going very unprofessionally by training our own people. Kisi ko pakdo and sikha do, but it should be done professionally from the chapter. The second line has to be prepared. Then we can all relax, and then still there is a lot of work for us to do in management. Just you continue. This is response.
So, I totally agree, sir. But the problem is that if you have a first line only, then you can train a second line. So what I'm just trying to say is that if someone is willing to take up respiratory practice, may not be incomplete, right? Is doing general pediatrics, but is interested into respiratory medicine, and they are managing patients with asthma. They're running an asthma clinic. So at least on the day of the asthma clinic, once a week, twice a week, they should have a spirometer. And unless until they themselves understand and learn how the spirometry is done, how the spirometry is interpreted, what are the problems which are there, it is very difficult to maintain the quality control with the second line. So gradually you can hand it over to a technician, to anyone whom you can train. But unless until at the back end, what can go wrong, then it can lead to so many errors. So I can tell you many a times you get reports which says that the spirometry shows restriction, and then you realize this child is clinically having obstruction, and no one understands why this spirometry shows restriction, because it was a poor maneuver. No one knows how to interpret the graph, and at the end of the day you realize this spirometry is not helping you. And then you ask the company people to don't do spirometries, and that is the end of the story for the asthma clinic. So I think
that is worst. I see these company people promoting their brands and just tell, sir, this is obstruction plus restriction plus, please prescribe this brand, that brand, they will do. So please don't listen to them. And as Ankit was telling in his sentiments, an eco technician cannot replace a cardiologist. It is as simple as that.
Yeah, so you have to learn it yourself, and only then you can take it forward.
So I think this is your golden word which Dr. Ankit has given to us, that if you want to interpret spirometry correctly, please learn how to do it, because unless you learn and you do it in front of you, probably the thing will not be as you expect. So I think all people who are on board today, they must take this message home, that please don't rely on reports which have been done at some other center and which are brought to you. Ideally, learn spirometry, buy a spirometer, install it in your clinic, do it at least once in a week in your asthma clinic, and you will be more confident in interpreting and using it for clinical use. I think this is a golden advice which you are given. So thank you very much. In the last, I'll request the convener of the module, Dr. Bafna, to give his concluding remarks, please, before I give vote of thanks.
Thank you, Dr. Rawat. Thanks, Dr. Subramania, Dr. Rawat, for again, thank you for giving us this opportunity. I think module has, I would say, has run well. If there are small corrections, we will do it. Whatever corrections are required, I think we can do it. And to the delegates, I think thank you so much for joining, because this is a different and difficult topic. So it was really nice of the delegates to interact. And as has been said, I think it is not difficult. You can do it. You should do it. And if you want to manage asthma patients, it is need of the time that the spirometer is there in the office practice of the pediatrician, because it is the need which is required to be done, and it should be done as far as possible by yourself, and quality control is important. But most important thing is it is not at all difficult. If you start doing it, I think after 10 spirometries or you will become confident. That's what I would say. And thank you all the faculty members, Ankit, Pawan, Sarika, lot of efforts they have put in for this module. And over to you, Dr. Rawat. Thank you so much.
So thank you, Bhavna sir, for again underlining this particular line that it is an easy procedure. It can be easily learned, easily done. We highlight this word easy, that don't be scared. It is an easy test, easy to interpret, and please start doing it and you'll be very happy. So we come to an end of this module from IPNRC. It is my pleasant duty to thank Dr. Bhavna as a national convener, and all the faculties, Dr. Ankit Parak, Dr. Pawan Kalyan, and Dr. Sarika for their valuable contribution for making this excellent module. Thanks to Dr. Subramaniam for being a guiding light for doing all the activities. Thanks to all the EB members to be supportive for us to carry out all these activities. And most important, thank you, Dr. Manjunath, for being a technical pillar for our IPNRC, giving all the technical help. And most important, thanks to all the delegates, almost 600 plus who were there on today at a time, for being with us and trying to learn, trying to appreciate our activities. And we hope that this association between teacher and pupil will go a long way in improving the respiratory health of children of India. Thank you very much, and we will continue to bring much more innovative programs and modules with the help of the committed members like Dr. Bhavna and Dr. Ankit. So thank you and bye-bye from IPNRC till we meet again. Bye-bye. Have a nice time. Thank you.
Thank you.
Thank you, sir. I'm leaving.
Okay.